Good morning. Please welcome the board chair of Georgians for a Healthy Future, Sar Medoff.
All right, good morning, everyone. All right, I know it's early. Come on now. We're going to try this again. Everyone from the diaphragm now. Let's go. Good morning. Awesome. Much better. It's great to see everybody. Ladies and gentlemen, welcome to the 14th annual Health Care Unscrambled. Whether it's your first year with us or your 14th year joining us, thank you for being here. Now, before we kick off, the depot staff has asked that everyone remember to pay for parking so that you don't get fined a parking ticket at the end of the day. It's Park Mobile Zone 70302. So remember to pay for parking. Now, as I was thinking about this morning and the word unscrambled, I was thinking about things that we like to be scrambled. And with the exception of scrambled eggs, there aren't many other good things that are scrambled. Nobody wants a scrambled TV signal. It's never good to scramble fighter jets. And if you're on a hike, it's better to stay on the trail than to scramble through the woods. And so I think we can all agree that the current healthcare landscape is a little bit scrambled. We have a fractured payer system, a tangled and conflicting web of federal and state policies, obvious inequality in health outcomes, too few services in rural areas, and limited access in urban centers. And there's an overwhelming need for mental health care. In many parts of our state, it's hard to get a healthy meal or fresh groceries. So you can imagine how hard it is to find a physician or a community clinic in those areas. And on top of that, how impossible it may be to pay for any of these things. So yes, the current picture, it's a bit complex, it's murky, confusing, or dare I repeat, scrambled. Today, Georgians for a Healthy Future and our distinguished speakers will help to unscramble it, to shine a light into the darkness, to bring some order to the chaos. At GHF, our mission is to collaborate with communities and partners to advance health equity for everyone in our state. Our vision is of a day in which all Georgians have equitable opportunities to achieve their highest level of health. Now, since our founding in 2008, Georgians for a Healthy Future has provided health policy information to community organizations, consumers, and leaders throughout the state. We teach consumers how to become strong advocates. We highlight the patient's perspective in hundreds of healthcare stories in the media each year, and engage with policymakers to spark change for a healthier Georgia. Before we kick off today, I want to acknowledge the great work that our staff puts in every single day. It is their insight, their care, their actions, dedication, and empathy that moves us forward. So thank you to our GHF staff for all that you do. Making Georgia a healthier place takes a village. And I would like to thank our champion sponsors, Georgia Primary Care Association, Georgia Health Initiative, and Hemophilia of Georgia. I would also like to thank our advocate, allies, support, host, and individual sponsors for your generosity, your donations, and your partnership. For these power our advocacy for marginalized Georgians at the state capitol and throughout the year. Today, we're delighted to have our keynote panel featuring two nationally recognized thought leaders. Joan Alker and Briscoe, thank you for being here today and sharing your hard-earned wisdom and expertise. I'm also thrilled to welcome our guests for today's legislative panel discussion, Senator Sonya Halpern, Senator Ben Watson, and Representative Sharon Cooper. We look forward to hearing your perspective on the dynamic healthcare landscape and the hard work going on across the street as the legislature works towards a healthier and more equitable future. We're going to start the morning with a story about a fellow Georgian that's drawn from the documentary, The Only Doctor. The director, Matthew Hashiguchi, is a documentary filmmaker and associate professor at Georgia Southern University. Inspired by his family's own difficulty accessing care, He started delving into the problems with rural healthcare in Georgia, and he spent 2 years filming Dr. Sharon Cooper and her work in rural Georgia. Today we're showing a 3-minute clip of the documentary featuring one of her patients, Michael Parkman. Now, Mr. Parkman is an uninsured man with a progressive degenerative disease. Because he's in the process of applying for disability, he cannot work. But because he cannot work, he does not qualify for Georgia's new Pathways to Coverage program. And Dr. Kinsella is one of the few ways that he can get regular, affordable care. His struggle illustrates the ongoing need for Medicaid expansion in our state. In Mr. Parkman, you may see a friend, a colleague, a neighbor, or maybe a family member. He is a fellow Georgian struggling to make the healthcare system work for him rather than against him. People like Michael Parkman are who GHF work for every single day. Unscrambling healthcare may admittedly take more than just one morning. But this morning, I encourage you to engage deeply, to think creatively, and to ask how our state can do better. As we gain clarity on the issues at hand, may we all run forward with renewed purpose and urgency. Starting today, let's make Georgia's tomorrow brighter, healthier, and more equitable. And everyone, welcome to Health Care Unscrambled.
So hey, how you doing? Samuel, I know you were here a couple weeks ago, but you're saying you had just started with later.
Wednesday.
But you want to come in before today, or?
I had to, like I said, I had to wait till I get my payroll to come in.
Okay, and of course, you know, we're always happy to see you. If you need to come in, you just come on in, okay? And I mean that. Okay. So you don't feel any better.
Slightly, but the pain is still.
Stand up and see where you're talking about. Take a few steps just so I can kind of see. Yeah. And then turn around. And that, your walk, that's not that much different than how you always are, right? How far can you turn your neck to the side?
That's it. Almost like a motorcycle.
I mean, basically, it's just cementing his spine in place. It doesn't have flexibility that you would do now, so he can't twist his degenerative disease of your spine. I notice you're kind of a sweaty guy.
Yeah. That's what carrying your weight around all the time.
Yeah. I mean, are you real prone to sweating a lot?
Yes, ma'am.
Okay, so maybe.
From hockey.
Is it hot in here?
I said from hockey.
Oh, hockey. Yeah.
How long do these sweaters typically last for?
About 2 or 3 months. Some days be worse than others, but it still be pain. Some days are bearable, some days are unbearable. Unbearable days I just stay out.
Have you been going to work? Yes.
No, ever since I've been working like from '96 to now.
Did you go ahead and apply for disability then?
They supposed to call and let me know on what's the penalty date.
Good. Okay.
They say you gotta have no income, but how can you have no income and have a house?
That
Make
makes
you
us
work.
take.
Yeah.
Yeah. And particularly because the process is so long, it takes about 2 years from the time you apply for disability until you get it in most cases. So, I mean, how are people supposed to live?
Is that?
I mean, you know, some people are with their family or something, they can make it, but if you don't have that, it's
Yeah, I mean, by yourself is rough.
yeah.
So you can't stay out, so you gotta go in pain. And it's only so much the job gonna take.
Yeah.
But you staying out, you know.
Yeah.
I'll push you.
Okay. Okay, good to see you.
Hope not see too much too soon.
I hope Dr. Norby is good.
I hope you feel better.
Thank you. All right, y'all have a good day.
You too.
Please welcome Bernita Haynes.
Take this mask off. Good morning, everyone. I'm Bernita Haynes, a senior attorney at National Consumer Law at Georgians for a Healthy Future. Happy to be here this morning and get ready to welcome our legislative panel. But before I do that, I just want to say that in partnership with the Only Doctor film team, Georgians for a Healthy Future would like to extend the opportunity to each of you to watch the complete film through January 15th for free online. Please refer to the program that you have in front of you and the film posters around the room for further details about that, as well as how to make the film available for your team, your community, or your constituents. Thank you again to the Only Doctor team for the important work they've done to highlight Georgia's healthcare stories and for allowing us to feature my first story today. Now, getting to our legislative panel today. Our panel consists of 3 members of the legislature, all with experience in healthcare and public health policy. Before joining the state senate, Ben Watson served in the House as the only medical doctor there. He's proven to be a thought leader in relation to healthcare and Georgians, and he sponsored the Interstate Medical Licensure Compact Act to add Georgia to the list of states that accept each other's medical licenses. Senator Sonya Halpern of District 30 believes strongly that healthcare is important and has fought for closing the coverage gap and issues important to women's healthcare in particular. Representative Sharon Cooper is a former nurse and medical administrator. She's also the prominent chair of the House Public Health Committee and has presided over some of the most consequential health bills that Georgia has seen in the last 10 years, with postpartum care, behavioral health, and infectious disease legislation. So, I would like to welcome them to the stage at this time. Just a quick note to folks in the audience, use the pens and note cards on your tables to write down any questions you have for the panelists. And you'll be able to raise those up, and Andy and Jana will come around and collect them during the Q&A portion at the end of this panel. All right, so let's jump right on into these questions. Starting with Representative Cooper, what are you hearing right now will be the most significant healthcare issues that House members are focused on for the legislative session?
Well, there's that big issue in the room called CON, the Certificate of Need. It's a big focus in the Senate, I understand, and the House had a committee also that looked at it this summer. Don't know where it's going, but I would think that that would be a major issue. Of course, we're always working on various healthcare issues, and we'll be looking at things to improve the healthcare of mothers across our state. So right now, we're just sort of, although it's been three already extremely busy days, sort of concerned in this way.
Thank you. And Senator Watson and Halpern, same question. What is the Senate focused on with respect to healthcare issues this year?
Excuse me, allergies even this time of the year. I do agree with Chair Lady Cooper that CON will play a role this time. I think healthcare is always on the forefront of our thoughts, related to especially here at this panel. It is a significant portion of the budget. It's 27% of a almost $34 billion budget. So it's the second largest item behind K through 12 and higher education, which is 54% of our budget. I think the governor laid out some of the issues yesterday. I think that there was some a little bit of a surprise for some of us and others not. I think the University of Georgia was the last university not to have a medical school associated with it, last major medical university. So I think that's going to be important, I think, to go forward. It has an MCG affiliation there now with about 60 students per year, and I think that will proceed with the University of Georgia. I think that the Medical College of Georgia, which is the state medical school and nursing school, physical therapy school, and PA school, and so forth, is going to continue to work with Georgia Southern, in where I'm from, in Savannah, for the medical school there. They will actually have medical students starting in this fall, and they will be enrolling, I think there are 40 students every year, so 240 when it's fully, 160, doing my math correctly there, when that is fully formed. Is that going to be expanded? I would hope so. It is being done in conjunction with the St. Joseph's Cameron Hospital there. And the governor announced yesterday a dental school, which has been sorely missed, as you know, and when I was in the House, that was one of the first tours I had here in Atlanta, was relating to the dental clinic here, because that was the #1 reason for people going to the emergency room at Grady, was for dental care. So I think that's been a wonderful success, but from a per capita standpoint, we're very low when it comes to physicians and primary care and other folks, including nurse practitioners, PAs, social workers, and so forth, and dental school students and dentists in the state of Georgia. So I think a dental program that the governor announced yesterday, I think it was $178 million in the budget with Georgia Southern, I think is an important step. So, you know, we know that it is important from a policy standpoint, but appropriations is where we spend our money and show our priorities.
I would add to that, as somebody who spent a good amount of time in 2023, from the time this session ended through the end of the year, in study committees that were specifically focused on licensing and trying to figure out where there's barriers and bureaucratic inefficiencies that we can get rid of. And out of I was on 3 of those, and all of the study committees came up with very specific recommendations, specifically around how we can kind of unburden the licensing either requirement at all, or just the qualifications needed for a license in especially high demand careers. And as healthcare is one of the largest items in our budget, it really is one of our largest high demand careers, and we recognize that we don't have enough providers across the state, in every corner of the state, to give our Georgian residents the care that they need. So a couple of things that I'm really hopeful that we will tend to this year will include a recommendation to fund, give more funding to the Nursing Board, of course, which represents the largest number of licensed business folk in the state, and give them more money to be able to more quickly get people their licenses once they've had the education that they need. So that's one example where I think we're specifically focused on licensing. The other conversation that came up quite a bit as well is how do we take foreign trained professionals and better recognize international experience in order to be able to get those folks to work immediately when we know that we need their help. And then the last area that I'll just bring up here too is for veterans. So veterans who have been medics, for example, how do we quickly get them, like some other states have done, back into the field once they've retired from the military, but still have the skills and qualifications, figure out a shorter time frame so that they don't have to start from the beginning in order to be able to appropriately get a license. So I think you'll see in general a lot of good work that's being done around licensing and including in the healthcare field.
Thank you for that. And speaking of the budget, Georgia does currently have a historic budget surplus and some unique healthcare dynamics, as we've already kind of touched on here. Given all of this, and the fact that you all have already laid out a couple of the priorities, what do you see as the general priorities for the health budget in particular this session? And I want to start with Representative Cooper.
Health budget? Well, I think Senator Watson hidden, you know, with trying to get a new medical school started. Georgia is the fastest growing state east of the Mississippi. We are now hitting close to 11 million people. If you go to Boston or up north, every corner seems to have a medical school. That didn't happen in Georgia. We were sort of a sleepy little state, and we had basically 2 medical schools, one in Augusta and one in Emory, and we were doing okay. And then all of a sudden, we became a state where people wanted to live, and they came very quickly on us. And so we've been behind the 8 ball, and especially with the dental school and all of the healthcare field. Mental health workers, people with PhDs in psychology, you know, so we have a really, you know, problem with not having enough workers to meet the needs that we have. And so I think that will be the huge priority in the budget, will be getting those schools up and going. And you never know what's coming up, and I'd also agree with Senator Halpern, not just the nursing board. And one of the problems with the nursing board, it's not just getting nurses into the system quickly, because you have to make sure that they're well qualified. But we're having a real problem and I hate to say this, I have a master's in nursing, with drug addiction in our nurses. And the board is having trouble dealing with this. There are so many nurses being reported that have drug addiction problems. I mean, drug addiction is a problem across our state in so many areas. The medical board also needs more money. We're having trouble getting the doctors, because the medical board also does other professions, such as PAs, and approves the nursing agreements that they have with the physician, and they are underfunded. So hopefully these are going to be areas, like Senator Halpern says, that are going to get more money in the budget so they can work more efficiently and more quickly to get qualified providers out into our state.
And Senator Halpern, you actually mentioned licensure. Are there any other priorities that you or your caucus would like to address in the budget?
Well, you know, there's never been a year where we are not talking about Medicaid expansion. And so, I mean, this is always going to be one of our key high priority areas that we would like to see the state do. And you all understand why. It is because we do want to improve access. Georgia still, to this day, is ranked kind of 3rd worst, I believe, in the country in terms of the number of people that we have who are uninsured. And so we do want to close that coverage gap, and we believe that Medicaid expansion is a pathway to make that happen. For the first time, it appears, at least I've heard more of the conversation in the House than in the Senate so far, but there seems to be maybe a little bit of an appetite to talk about Medicaid expansion. And even if it's not full Medicaid expansion, I keep hearing the Arkansas model, which is something that we should explore, because at the end of the day, the word Medicaid expansion has somehow become kind of toxic. And just the other day, the majority leader, Steve Gooch, was quoted in one of the newsletters saying that Medicaid expansion has become a toxic word, but maybe there would be a way to get there. And I think if we're all in agreement that there's a way to get there, that's a good thing. We can call it kind of whatever we need to call it, but let's get it done, and let's close that coverage gap. So I would say Medicaid expansion. The other thing that I want to raise here also, though, is now comp waivers for folks who have disabilities, and they need the community help, that they need the home care help and the support for home care. The Congress had in 2021 passed they allocated a ton of money that went to every single state that was meant to increase the pay for home care workers and allow states more flexibility to be able to grant more families those kinds of opportunities. Here in Georgia, we still have 7,000 or so families on a waiting list, waiting for now comp waivers. Each year, we have been, in very small measures, increasing the number that we have approved, but every state has until 2025 to, in fact, tell where the money is going around this issue of home care help for families and people specifically with disabilities. And so I'm hopeful that we'll be able to continue to increase the number of families who are able to access that care, and more importantly, also increase the rates that we are providing to the folks who are doing the work, because they're too low, and there is a dearth of personnel in that area as well. And then, because I always want to mention tobacco tax, this might be a good place to do it. You know, we have this huge surplus right now, and so you might ask, well, why talk about instituting a higher rate for tobacco tax now? We're swimming in this surplus, and we are. And there's a lot of great initiatives that we can do, including expanding Medicare, because of that surplus. But at the same time, we have started to see a trend over the last couple of months where we are not actually meeting the expected and anticipated revenue. And so because of that potential slowdown, I mean, I do think that there's always an opportunity to think about where might you actually generate more revenue. And on the tobacco tax side, we are not at the national average. We're nowhere near the national average at the moment. And I want to give this stat because I know I have it. I mean, yes, but the most recent, there was a study around this, and the most recent fiscal note that Chairman Huffstetler got showed that if we just went to the national average, that would generate an extra $515 million a year. And so, you know, I think that there's an opportunity to think too about what do you do with a surplus, and I think the governor has already indicated that he wants to use surplus dollars for kind of one-time projects, right? He doesn't want to commit an ongoing expenditure of those money, which is perfectly understandable. But on the other hand, we still do have opportunities where we can generate annual funds through increasing that tax that then would allow us to maybe be able to fund some of the stuff that we still need to fund that will be needed on an ongoing basis, and that and as opposed to either or strategy might be one that if we had the political will to do, this could be an interesting year to do it.
Thank you for that. And before we move on from the budget, there are a couple of other issues I'd like to bring up and hear your thoughts about. Restoring and increasing funding for the Georgia Housing Voucher Program, which, as folks may know, provides housing to Georgians with serious mental illnesses. And then also retention bonuses and pay increases for public benefits, Medicaid eligibility workers at POCS. Thoughts on those two issues?
Yeah, I like the way you phrase that. It's an interesting year to consider that. And I think it is. It's always an interesting year under the Gold Dome. We have many things in play at many different levels, I think it will be an interesting year. Let's define a little bit, sort of unscrambled, the scrambled, relating to Medicaid expansion. So when I became chair of HHS 5 years ago, the first bill that Governor Kemp did was Medicaid waivers. And I'm sure almost everybody in the room is familiar with that. So that was a waiver for the ACA, and that was the way that Georgia did Medicaid expansion. So let me help all of us remind everyone what we did there. So what had happened with the U.S. Supreme Court is that they had said that they couldn't force states to make a tax, so to speak, and that's what a fee really is in most situations. So there was a coverage gap between 100% up to 137, 138% of the federal poverty level. And the way Georgia did it was that we did it similarly to the Arkansas method of a reinsurance. In other words, the 138% down to 100% is reinsured. And that does things that are good for the patients. And what I say in my health care committee, and I'm sure Senator Halpern has heard me say this, if we do what's right for the patient, everything else will generally fall in place. So from a reinsurance standpoint, so we can all be on the same page, is that 100% up to 138% is part of the ACA and the exchange. So now it's up to 100% up to 400% of the federal poverty level. And that does one simple thing that the Arkansas plan does. It provides insurance for those people who are in poverty from 100% up to 138% now, and their premiums are 100% paid, period. They pay no premium, no monthly premium, or anything like that. What that does from an acceptance level, because we talked about earlier that many physicians and hospitals and so forth don't accept Medicaid. So that gets them off the Medicaid rolls and gets them on an insurance roll. And for the most part, insurance has better coverage, better care, is more accountable relating to the care for that patient. I saw the hospital associate is in here earlier. I don't see Anna now, but I'll call her out. But that gives a better reimbursement for the hospitals and for other providers. So it's a win for the patient, it's a win for the hospitals and the providers. I think that's a good thing. And let's talk about the numbers there, because I just got the numbers yesterday from the Department of Community Health, and bear with me here for a second. There's an estimate, and 654,877 individuals. So for those taking notes, Andy Miller, if you're taking a note, over 650,000 individuals between 100 and 138% income range have signed up for the ACA plans this year in 2024. That's a lot of people that were uncovered prior to that legislation. Now, admittedly, it's been delayed. It was approved by the Trump administration, sued in the Biden administration, lost in federal court down in Brunswick, lost terribly, as a matter of fact, to the point that they did not appeal. The Biden administration did not appeal. The question is, why did they not appeal? They did not appeal because they would have lost, because it took Georgia a while to get it done. And we did it well. We did it to the point that they did not appeal because they were concerned that it may form a precedent. Now, the one that's been a bit of a challenge, and I would challenge you to help our patients to get enrolled, is that 100% on down. And that's the one that's been controversial. That's the one that requires 20 hours of work or 20 hours of volunteer work. This is 20 hours a week, 80 hours a month, or going to technical college or going to college. That's the one that's been controversial. That's been what's been part of that unwinding aspect related to that. So that number, there, according to the 2022 census status, there are over 280,000 individuals in that 100% of federal poverty level or down that are uninsured. Now, unfortunately, because of the delays and the suits by the Biden administration that took us to court, it was started in July of 2023. And it has been a challenge to get people enrolled. And that's what I would hope that this groups, I should say, would help get folks enrolled. And the point I would like to make and make earlier is that individual in that primary care film is that guy's, he's disabled, right? And she said it takes about 2 years. Well, it may take 2 years, it may take 6 months. I don't really care what the number is. It's really too long for that to happen. And who has control over that? Disability is part of Social Security, right? We get accused of going to Washington, D.C. a lot. but we are not in Washington, D.C. We don't have control over the disability. That's, our U.S. senators and our congressmen. It is a challenge to get people approved for disability. They do take it in independent examiners, they do that, and many times they do get not approved. And I think the average is about a year before someone gets approved. At least that's my last number that I have. I I'll stand corrected, someone to have better numbers. But from a federal standpoint, that does need to be addressed, and Senators Ossoff and Warnock would be great advocates for that, I would hope. Because if you can't work 20 hours a week, or volunteer 20 hours a week, or go to technical school, or go to college, then what are you? You're disabled, right? And so you should qualify for disability. And then you would have health care, correct? You would have health care through Medicare. So that's the way I look at Medicaid from that standpoint. Arkansas basically brings down that 100% and below to a reinsurance program. And therefore it's better reimbursement. More physicians, more healthcare workers accept the insurance and do not accept Medicaid. And I think that's an important distinction to know and to understand. You know, the topic was brought up. I think we need to discuss it. It will be interesting how it all shakes out. You know, that's why they elect us to make decisions for the people. We don't always make appropriate decisions, and democracy is very messy, but eventually we do get things right. And we continue to work at it, because I think we have the interest, as I stated earlier, we have the interest of the patients in our heart, and that's what we should be doing. That's what we should be looking out for. And I didn't mention federally qualified health centers, over 250 in the state of Georgia, for people who do not have insurance and pay on a sliding scale. I'll just leave it at that. Sorry it took so long.
No worries. No worries. And I just want to clarify that Medicare is age-related, and Medicaid is for those who are disabled.
That's right. So just education, Medicare is generally 65 and above, or as I mentioned earlier, disability. That's Medicare, right? Medicaid is the state program for people who are in poverty, and that is state administered. We generally pay on a 60-40 level, 60% feds, 40% state, and what we were denied was the 90-10 coverage, from a 90% to a 10% coverage, which would be that 100% now. That's in the weeds. It is a 90% match. The feds pay 90%, 10% would be Georgia. All right.
Thank you. And since we're on the topic of Medicaid, first of all, I think Representative Cooper, you have your hand raised. You look like you want to jump in. No. Okay. But since we're on the topic of Medicaid, let's talk a little bit about Medicaid, the unwinding, which you briefly mentioned, Watson. Georgia began its Medicaid unwinding efforts back in April of last year. Between April and December 1st, more than 440,000 Georgians had their Medicaid coverage terminated. Most of those Georgians are children, and many are still eligible for coverage. So what bills or funding in this, are in this pipeline, or should be in the pipeline, in your opinion, that would help address this particular issue? And that's a question for any of you on the panel.
Well, I don't usually defend departments, but this is one time I will defend the department. First of all, they had just had to re-certify all the providers in the state. It was federally mandated. So they'd just gone through that, trying to run down everybody, tell them that if they didn't get their recertification by a certain date, they weren't going to get paid through Medicaid. It was a big scramble. And then they got this one. It did have glitches in the beginning. They are working on the glitches. There is some personal responsibility to this. When people don't open their mail, when, they let it sit and they don't reply back to it. But the department has put extra procedures in. When somebody, looks like they're going to lose it, they're trying to run them down. It's not always easy. And so they are trying really hard. I don't think that we need to be passing any bills or doing anything to encourage them. They're the ones that are getting hammered. They know that we're all looking at them and saying, why is this happening? Can you move faster? And I would just say, I think, they're getting their job done. It's not without kinks. Hopefully the feds will never say we have to do this tote thing all over again like they did, because it was federally mandated.
mean, I'd have to agree. It's federally mandated, so we have no choice but to do this. And I think that the department initially, because they understood kind of the big scope of this project, really tried to, in order to avoid some of the big problems with a lot of people, they kind of tried to slow walk it. So they tried to start with a smaller number of people, work out the kinks, and then the next month add a larger batch of people. But it is hard when you don't necessarily know that you've got the right address even. You don't necessarily have emails for people. You don't necessarily know how to reach the people that you most need to reach. And this is where I think the care providers really are key to us being able to reach the people, because our managed care folks know who these people are and can actually help us reach into them. The other thing that's complicated on the requalification is that, you know, like, you can only do it when your time is called up. So you have this very small, limited timeline in which you can take the action once you know that your name is up and it's now time for you to do your recertification. It's really complicated. I don't know about bills or legislation, but what I will say is that if you think about it as a partnership, all of us in this room and us as legislators and the department can be partners in making sure that Georgians remain with their Medicaid protections and that the children are able to still have the services that they need. I know in my district, I represent part of South Fulton County. And so I actually had it's the Department of Community Health, I had them actually come and join me at a meeting with the 8 mayors who represent South Fulton and talk about the process so that the mayors also can reach out to their constituents and make sure they are also aware that this process is happening and how they can plug in. And we are still right now planning to actually do like a health day in each of the 8 cities and bring some of the managed care providers to help actually show people how to actually walk through the online process of recertification. The other thing is the packets are really thick. So for people who are receiving the packets in the mail, they are pages and pages and pages of very intimidating language if you're not used to that. And it also includes just, again, because the department is trying to streamline some of the process, it also includes information on SNAP for the people who would qualify for that so that they can kind of handle everything all at once. But it's complicated. And I do think that all of us have to see ourselves as partner in the effort to get it done and have it done well.
Thank you for that. And I'll go off script for just a second and shout out Georgia Watch's work with community health workers, because I think this is a very important role that community health workers can jump in and play and make sure that people are not losing their coverage just because they don't know how to wade through all of these papers and so forth. So, all right, well, let's keep moving. Let's look at the coverage gap. The House and Senate both led a study committee in 2023 that examined possible changes to Georgia's Certificate of Need laws for hospitals. The House committee also discussed closing Georgia's coverage gap, potentially invoking the Arkansas-style model that's already been mentioned here. What do you think we should expect to come out of the findings of those study committees this year? Yeah, we kind of we touched on it, but not fully. Any other thoughts about it? Okay. We touched upon it, but I don't think we fully answered it. So I want to also just ask Senator Halpern about maternal mortality issues. This obviously is a huge issue in Georgia. I think you mentioned earlier that we're like 3rd and uninsured. We always hover between 3rd and 4th. We're always pretty up there too for maternal mortality issues, right alongside Texas. How might Medicaid expansion help address this issue, especially for Black and rural
So I'm gonna start, because I am gonna say that, let me first give a hat toss tip to Representative Cooper. So one of the things, let me just say from the start, that we have done in my time in the legislature is every year we have found a way to expand the benefits for postpartum moms. So my first year, I think we said we're gonna expand Medicaid for postpartum moms and their children to 6 months postpartum. And then we came back and expanded it to a year. And I know that you were really one of the big drivers on that effort.
We had $1 million.
Right. Big, big deal. And so I think that what that says is that we all recognize that we have some work to do around the issue of maternal health generally in the state, and that we can do better. There are statistics that show the U.S., across the U.S., and Georgia being one of the worst states in terms of maternal mortality. And I think we can all agree that we do have work to do to shore that up and to figure out how to make sure that every woman, including women regardless of where you live, urban, rural, Black, white, Hispanic, that all women of childbearing age are able to access the care that they need, are able to make sure that they have OBGYNs that they can get to, that they have somebody that is tracking their pregnancy. Because if you've ever been pregnant or been around anybody pregnant, walking your partner through a pregnancy, every step of the way, frankly, it's a miracle, and anything can go wrong at any time. I myself have 3 kids. So we do need to make sure that women have access. You've heard, I'm sure, the statistic that there are 80 counties, just about half of the counties in the state, that don't even have a single OBGYN. So some of the work we've got to do really is around providers. Some of it is, and Medicaid expansion conversation we just had, is around making sure that patients are insured, that we have good reimbursement rates for providers, that we can get people the access that they need, and then there's other stuff like workplace accommodations that we can talk about to also help pregnant women or women of childbearing age. But I know we're going to be a little bit on the opposite sides of the table on this, but I think where we can agree is everybody knows that we have to have a better ranking, even just in terms of perspective for people who think about coming to the state of Georgia. We don't want them to see this state as the state where if you come here and try to have a baby here, that you are not going to get the care that you need, and that being here would be a sentence to death. That is a very bad image for our state that we have to shore up.
Okay, I have a lot to say about this issue, and a lot of it's my pet peeve, and I don't think I'm disagreeing with you, Senator. And we've already hit on a lot of these. I mean, Dr. Watson said, new medical schools. We've pushed 300 more medical students already are attending the Medical College of Georgia because we're pushing the physicians. We're doing everything. There's new residency programs because half the physicians stay where they do residencies. So we've set those up. They're very expensive. Hospitals have to be qualified. We've already been working on so many of these issues. We can do better. But I have a real pet peeve. First of all, I think people need to understand that rankings are done on apples and oranges. Some states only report maternal mortality deaths in the first 60 days after delivery. We go out a whole year, but they lump us together. And now, they've started to put items in and relate them to maternal mortality that, in my opinion, don't belong there. Now they were including drug overdose deaths in that year. What does that have to do with delivering a baby? Is it important? Yes, it is. And the state needs to work on overdoses, but it needs to be in the mental health field and not attached to pregnancies. They're also doing homicides. What does that do with a mother delivering and whether she delivers a healthy baby or not? It needs to be helped in public safety, along with traffic accidents. If if a mother's in a traffic accident in that year. So, can we get back to the basis of what hemorrhage, this kind of thing that really is directly related to a mother's pregnancy. The other thing is, one of the tactics that people use in election years and stuff is to scare people. I'll give you an example on the federal level, just really POs me every year. We're going to take away your Medicaid, or not your Medicaid, your Medicare from seniors. You hear it over, it's already started, I've already heard it. We're not going to take away Medicare for Senate, because let me tell you, no U.S. congressman or senator would get reelected if they touched anybody's Medicare that they're getting it right now. I happen to be getting it, I'd be fussing if they did and voting against them. But it's a scare tactic, because people don't really understand the process. Now maybe changes need to be made with 40-year-olds to keep it going, but not now. So now what we're hearing is, oh, we're the worst state in the world. Our mortality rate is so high, it's worse for Black and brown mothers, which it is. But let's put it in perspective. And I wish every baby that is conceived was born healthy, and there were no problems, and we lost no mothers. Get that for breast or anybody else. My mother died when I was 12. That affected my life. I cannot imagine what it would be like to go through life never knowing my mother. It was bad enough at 12. But we deliver somewhere about between 110 to 130,000 babies a year in this state. We lose somewhere between 30 and 40 mothers. Now that's too many. If you take out all those car accidents and overdoses and that, realistically, the doctors can save about 60% of that, to maybe 20. Others, they can't. But we're working on it, and we're learning things. There's now research that shows that African American mothers, just like African Americans have a genetic predisposition to sickle cell anemia, that they may have a predisposition genetically to hemorrhage. If that's the case, then we need to make sure that we let that know, and our medical people know, that you may have a mother predisposed to hemorrhage, so that we do everything we can do. So we're working on those kind of things as we find out more about it. And we're doing all this, but we are not having hundreds of mothers die in this state. And what we're doing with all this hullabaloo about how bad we are, instead of talking about what we've done, and Dr. Halpern, instead of how we talked about some, and how we're working on it to investigate, we're scaring Black and brown mothers to go and take alternative methods of delivery, to not go to the hospital, to have home deliveries. If you're predisposed to hemorrhage and you have a home delivery, what do you think's happening if you get in trouble and you start hemorrhaging? The people that want to do it at home will tell you, oh, well, we're within 30 minutes of a hospital. You waiting on an ambulance in rural Georgia, and you get to the hospital, we can lose mothers. So what I'm saying is, we're working on it, and we've come a long way, we've got work to do. But as we talk about that, could I ask you not to scare Black and brown mothers in this state to death? Can we talk about it and realize in realistic numbers? And it is a pet peeve of mine, and you can tell it. And nobody has worked harder to get bills passed that help with maternal mortality and making sure mothers get care than I have since I've been here. It's a passion with me. I have a master's in nursing. I taught OB nursing. I know what I'm talking about. I've seen I've been in delivery when it was the happiest place in the world. And I've been in delivery when it was the scariest and the saddest place in the world. So I would just ask all the groups, let's not scare everybody to death. Let's talk about what's needed, how we're trying, women need to go, and we need to make it prenatal care available. And with that, I'll say, there's something else you probably don't know. We used to have one nurse midwifery school in this state, one, where RNs could go to get a master's degree in nurse midwifery. Everybody know that we have a new one down in Milledgeville. They're taking experienced nurses, and a lot of them are from rural areas, and they're going to Milledgeville to the university and getting their midwifery degree. We're doing all sorts of things across the state to help lower our numbers, to put us higher up the list on maternal mortality. But just realize when you hear it, that there's often, you can make the numbers say anything, and often you're not comparing apples to oranges, and talk about the things we're doing, and encourage women to try to seek medical care and to do the things that they need to do. But the other thing I said last night on television, which I will say, I don't think there's any mother say, oh, at home deliveries. We only deliver, normal deliveries. I'm beginning to believe that there's no thing as a normal delivery anymore until after it's over and everything went okay. Because women are now having babies when they weigh 350 pounds, when they, have diabetes, when they're in their 40s, when they have other predisposing health issues. And that's a problem, because we're saying if they don't have health insurance, maybe that's why they haven't had and gone to the doctor. But we're dealing with lots of problems related to pregnancy these days, and women need to go to where they can get the best care and not be scared. And then I'll get off my bandwagon.
I know, and I'm going to pick up the bandwagon and say, here's what I think I hear, and I hope everybody else heard too, is that we actually do need more trained professionals in this state who are able to account for and accommodate for, who are trained to deal with the variety of situations that they may find, whether it's somebody of a certain size or with predispositions to certain disease, or whether it's kind of genetics that drive the outcome. We need doctors in this state who want to come here, who want to work here. We do need more doctors of color. We need to pay our providers more so that they want to stay here instead of going to neighboring states. And we need to close that coverage gap.
So, listen, I think we're all in agreement, to be honest with you. I mean, I think that one death is too many. I'm a grandfather from 6 weeks ago and about 3 weeks ago. So my daughters-in-law are postpartum. The coverage gap is not there when it comes to pregnant mothers. They're covered, and they're now covered up for a year afterwards. Certainly prenatal care plays a role, postpartum hemorrhage plays a role, depression may play a role. I think those things need to be defined. And we actually did pass legislation when Senator Dean Burke was with us, a retired OBGYN who's now in Department of Community Health, relating to defining that, adding postpartum death to that aspect that needs to be studied and looked at, and trying to define what we can do. So I don't think there's a disagreement on a need to do. It is certainly, I think, a role for government to help with that. But we may disagree on some of the inflammatory language that's used, but I think that we're all on the same page about doing it again what's right for the patients, right? Thank you. I've got to head on to another meeting. Thank you all for having us, having me, and it's been enjoyable.
Thank you. And in the interest of time, to make sure we have time for Q&A, I'm going to just have one more question for the panelists. But before I go to that, I would just like to uplift what Senator Watson just said. One death is too many at the end of the day. And also Senator Halpern's comment about the need for more doctors of color. I just want to emphasize those things. Last question. And this was initially for Senator Watson, but I'd like to hear your thoughts as well on it, Senator Halpern and Representative Cooper. There was a big mental health bill, HB 520, that currently sits in the Senate Health and Human Services Committee. Do you all expect that committee to relook at that particular bill this session? Are there any parts of it that you think are important? Just generally, what are your thoughts about that bill, if you have any familiarity with it?
So I think I'll take it because the House passed out HB 520 and it's now sitting in the Senate. A subcommittee was created specifically around that. I don't happen to sit on that subcommittee, so I can't speak to exactly the work that's happening. But I'll use this as an opportunity to say that it was obviously focused on mental health, but also behavioral health. We've talked just a little bit today about substance use disorders. And I mean, I think this is an area where this bill also would help to provide some additional help and support for people who are undergoing that. We know that we need more behavioral health specialists, that we don't have enough psychologists, psychiatrists in the state. And so some of the pieces of the bill would have created pilot programs to test certain things, would have allowed us to just move forward. I'll take a step back and just remind everybody that the year before, in 2022, when we passed HB 1013, that was a really major mental health bill. Not that we've not done anything before then, but that was really our big kind of come out moment. And where we said, we as a state are gonna acknowledge that mental health and physical health are equated to each other. We're gonna make sure that insurers treat both the same, and we put a lot of money also behind that bill. We will continue to make steps. I just can't tell you exactly where we are with this one now, but hopefully we will, in one way or another, whether it's this bill or not, we will add to the work that we're doing in mental health and substance use disorders this session.
Thank you.
Let me make something clear. I'd like, in case you didn't hear it, Ms. Hayes, I also believe one death is too many, and if I didn't make it clear enough, I don't know how else I could make it clear. But the Democrat women and the Democrat Party in the House have taken it upon themselves. They're going to, I understand they said, they're going to go to the well every day as a group and talk about how women are dying and how we're not basically doing anything or what we need to do. So that's what has gotten me started on this, and being on Lawmakers last night with somebody that has that bill. So that's what, but it is a passion of mine. Okay, about the mental health bill. Okay, and it's a little funny. When the 1013 went to the Senate, it was 72 pages, I think. We don't do 2,000 or 5,000 page bills. But 70-page bills, pretty big, but they have been bigger a couple of times. And so we sent over the bill this time, last year, and it was 50 pages. And the senator handling that, who's my senator, she's great. And because of what people were talking about in the senator and some of our more, I think, extreme Republicans, because I call that both sides, my senator sat back over and said, don't send me any more mega bills. Break the bill up. So we are breaking that bill up, and we're going to send y'all smaller bills. Maybe you can read them, but they're only a few pages long. I'm teasing. I'm teasing. I'm carrying one of them. It has to do with workforce, because here again, we don't have, and like Senator Allen said, we don't have people that work in the mental health field. We can pass these bills. We can say you're going to be able to get mental health care, but if we don't have anybody to treat you. And one of the things when they talked about licensure, our state, I think, requires that people who are psychologists, clinical psychologists, have to have a 3-year internship after that. Lots of states only require 2. I mean, if the committees look at it and they don't find a reason for that extra year, if we now change it to where we only require 2, and we're going to turn out good clinicians, that will get people out to us more often. So we talk about the committees. These are the kind of things we're looking at, and the bills coming over. And so I think the Senate will be getting a lot of smaller bills. And that will take take that bill apart. And, you know, one of the things that there was some, on the Republican side was, were we just going to pay for everybody to go to school like they're doing, like the president in Washington, you know, just want to do away with school debt? And somebody said that at a house, and I asked to be recognized and stood up, you know, and said, well, our bill, unlike what is proposed in Washington, does not wipe off the debt for a psychologist like it would for somebody that majored in tiddlywinks in Washington. Well, that didn't make some of my people mad, you know, but I like to say I'll go after either side. I just tell it like it is. Zell Miller called me the little legislator that tells it like it is. Anybody that calls me little is nice. But I do, it's just I'm straightforward with it. And if you want to know the straight, well, just come out, I'll tell you. I don't know how to be any other way. I think it works better that way. So that's our answer. And I'm small business coming in.
Well, you actually, while they're talking, you referenced something though that's really true. Like the mental health bills, even though they seem like they would be very straightforward, there are a lot of people that you would not expect are paying attention who interpret certain pieces of the bill and really kind of get wrangled up around their interpretation, and it's generally not on my side of the aisle. And so it's causing, yes, but it makes it really much harder, right? Because then there's this tension and everybody's trying to balance, particularly when, you know, you're the party in charge and you've got a lot of people coming after you around an aspect that's been misinterpreted. So it's not easy what we do, but we try to ultimately keep our eye on the goal and what can we do to really help Georgians every day and on the patients.
All right, thank you both. So now that we've gone through all of my questions, let's turn to some of the questions we have from the audience. This first question is about navigating enrollment. So there is a program that certifies by feds and by Georgia navigators who assist patients in enrolling in the Affordable Care Act insurance policies. Is there a similar program to help Georgians with Medicaid currently?
I don't know, not from that. I mean, I know that.
Oh, use the mic just in case we can hear you.
I'm sorry, I know that people that had dropped off and hadn't responded, I know they were having individuals reach out to them, but I don't know about an overall program. And I do know that some people tried to call the departments and the phone lines were down, they couldn't get through, and that was the problem. So, and, you know, it's not without problems.
Okay, thank you. Second question, and this goes back to similar to an earlier question on the panel. In other states that have recently expanded Medicaid, the expansion has been tied to certificate of need. Both of these are on the legislative agenda. Do you think they will be tied together or stand independently, and why?
I doubt it. I mean, the hospitals, when they came, and Anna's probably here somewhere, the hospital said, and what they wanted, we'll agree to this changes on CON if we get Medicaid expansion. Well, legislators don't like to be told, and the governor especially, that, you know, we'll do this if you do this, you know, so I would sort of think that they won't be tied together, but, you know, I don't run, as I like to say, I don't run the zoo, and thank God, and I think they're probably going to stand alone. They're both very controversial, so it's going to be an interesting session.
I think I'm in agreement that each bill would stand alone, but why people are talking about it as being tied together is because I do think that there is solid thinking that says if we're going to drastically reform certificate of need, then we're going to need to make sure that we are expanding Medicaid in order to make sure that existing hospitals ultimately, right, aren't further stretched because the insured clientele now has the potential to have alternatives and other surgery centers that they can go to, because patient mix really is the bottom line. Like, what makes a hospital survive or not? Patient mix is a big piece of this. And so if your insured patients make the choice to go to the brand spanking new facility down the street instead of the existing facility, then you're actually disturbing the mix even further, because you need the private insurance or the insured in order for your hospital to not destabilize further.
Well, you're right, and probably that comes out of the Senate has, did you pass the total repeal? Or did it passed, didn't it? A total repeal CON? No, but it was proposed. The study committee wants, there's a big movement on the Senate side to do a total repeal. And that would be, I can see the Medicare, Medicaid being attached to that, because that is very drastic. And the House, I'm in the next level down from leadership as a chairman, but I was on the study committee. I don't believe there is any appetite in the House for a total repeal. There's for certain changes, but not the total thing. It's happens in all things. Just let me say, I really have a problem. People don't do well when you move them too fast, and when we go in and move from here to there on a bill, it usually is not the best way to handle things, but we'll see how the push goes.
Thank you. For those patients falling between 100 and 138% of the federal poverty level, are their medications covered? Are there co-pays at outpatient visits?
I think so. And I want to say that, like I said, I don't run the zoo. I think the Arkansas model works really well. There are studies that show that people on Medicaid that the outcomes on Medicaid are about as good as not having anything. It's not the best program in the world, anywhere in this country. And so giving a person their own insurance policy, I think everybody ought to have it there and we pay for it. First of all, it would cut down with a lot of the red tape and trouble getting through and re-qualifying for Medicaid and all that other kind of stuff that goes on, which is horrible, because we help people that are having trouble with it. But the other thing it does, it makes you not stand out. You don't feel different. You don't go with a Medicaid card. If you have your own insurance policy, you go with an insurance card, and the rates are better, and there's not that stigma to it. So, in my opinion, should that come up as an option, I'd certainly, think that having your own insurance card would be a positive thing.
Do you know the current number of people waiting for Medicaid waivers? Medicaid waivers.
That's the now comp waivers for.
I think so. Yeah,
it's still. The thing is, we added another 100,000 this last year, but then you get more people behind it who still need it. So the number is not dramatically changing. The last number I had heard was 7,000. That number could have climbed.
I'd certainly rather see people. If you've watched the news, anything about the latest thing, we have an assisted living where people pay a lot of money, and there was they were not watching the people in memory care like they should have been. Staffing was a problem, and the man who they knew, one of the last things to go often is your sexual urge, and sometimes, especially men, have a problem with it as they have a form of dementia, and raped another patient, and another patient got an employee's car and drove 40 miles and before they ended up in the hospital. So we would, in my estimate, would be really a whole lot better if we could safely keep people in their homes. They would be happier, and if we could wipe that off, it would be really good. But here again, the people that run those businesses will tell you they cannot find help. And people that pass background checks and who want to do this and want to be responsible, and if they're supposed to show up every day taking care of an older person in their home, they can't find them. They have on the way of the Etzel or something. I don't know how we get them back.
Last two questions here. How many new residency seats are proposed? Are there discussions to broaden ways for helping future medical professionals? How many new residency seats are proposed? And then are there discussions to broaden ways of helping future medical professionals?
Okay, I don't know how many residencies. We've been on a pretty big push for hospitals. For a hospital to qualify, like if you're an OB resident, I'm gonna pull a number out of the thing. Before your residency can be certified so that you can come out of a residency and be board certified, you have to deliver 125 babies. I don't know what it is anymore. And so you have to be in a hospital that sets up that kind of residency. You have to have enough deliveries that if you have 2 or 3 residents over 3 years or 4 residents, they're going to meet that for their students to have that opportunity. So starting a residency, first of all, the hospital system has to be big enough to handle and provide the experiences. They have to have qualified faculty members, and it's expensive. It's about $140,000 a year for residents. So our big systems have been really involved. So, and they are, like Morehouse and Mercer, yay for the 2, because they are sending their medical students out and doing clinics across our state in rural areas. They are leading the way, Morehouse and Mercer, to help us get doctors to realize, maybe it's not so bad to live in the country, and maybe if I can have a residency somewhere in Georgia, I might come back. Now, I will tell you, my husband went to Byronville, Georgia for a year, almost 2 years to pay back his loan years and years and years ago. He's passed away now for 10 years, but he graduated in 1962 from Emory. And thank God we weren't married, because Byronville, Georgia has 2 streets. And he almost starved to death, but he stayed till he paid back his loan, and then he went to also a rural area, because Woodstock, Georgia was pretty rural at that time. And even with residencies, you have to realize that usually residents are married to other educated people, either husbands or wives, and they want to be in a place where there's good schools, which we're working on, good schools, they want good health care, they want to be able to go to the theater or to the movies and so forth. So a lot of times, our rural areas are not to entice them, but my feeling is, gee whiz, let's pay back their loans. And if they'll go somewhere for 4 years, and we reduce greatly their medical school costs, I'd rather them stay. But if they want to get out, okay, as long as I got another one that we can reduce their loans, and they'll go back in that clinic and pick it up. It's not the ideal thing, but if it'll get medical care out in those communities, let's do it. One of the things we need to look at, which I hope we will look at, is bigger reimbursements. When Dr. talked about the federally qualified health programs, I want to tell you, thank God, federally health qualified systems across the state have about 250. You walk in, they will treat you if you don't have, insurance. If you have a little money, they'll do it sliding scale. And they can get doctors and people to work for them quicker than we can. And you know why? It's a federal program, and they pay off their loans quicker. And so, thank you. If you ever go to one or know someone runs one, thank them, because they are our safety net across the state for good care for patients. So I talk about them all the time and tell people that can't. The other thing I want to tell you, probably don't know about. Anybody heard about it? Not the program you see on the news. You know about goodpill.org? Okay? Goodpill.org, pharmacy. It's been going now for about, I wrote that bill, I don't know, 7 or 8 years ago. Go to goodpill.org. If somebody cannot afford their medicines, send them to goodpill.org. There's about a 5-minute test that's not like signing up for Medicaid. They can see whether that pharmacy has their medicines, and they can get their doctor to send a prescription or get it qualified, and they are sending out medicines, it's only mail order, across the state, all over Georgia, for about $6 for a 90-day supply of medications if they have it. They are recycling medicines that would be destroyed from drug companies and all. Not out of date, it's a certified pharmacy, but they are doing that for Georgia citizens, and we need to get the word out, goodpill.org. And they don't do any background checks to see if you really need it or not, but it's a safety net things on medications. They don't have every medication, but you can tell right away, and if you're on a certain medicine, they make sure that they know that they'll be able to keep enough medicines of that thing to keep people on it. So we've got safety nets across this area. The one thing the legislature does not have, and you've already realized it, we have no way of getting the word out about things we pass. We don't have any money for public service. We have to beg. I have asked all of my House members, please send this out to your patients. You know, when you do a newsletter, can you talk about goodpill.org? Well, who knows whether they do or not. It's the same way you pass a law on public safety. The only way the public safety laws get out, or a lot of the DAs or something, is if their societies pass it out. And it's a real loss. We really need some way that we can do public service announcements to get things that we do to let people know, like if we have a way for people to get help with signing up, that we can put it out. We don't have anything. So if I ran the zoo, that might be one of my first things.
I'm glad you mentioned the medical professionals to getting your student loans paid off, because that was the rest of this question, like how do people bear that burden? This person did mention that, you know, a 500K education is a really daunting burden to have, so I'm glad you mentioned that.
Well, especially now, the federal government just cut fees on doctors. And they've been, I mean, doctors, you know, used to the old town doctor who was the wealthiest person in town, that is no more. Now there are some specials. If you do facelifts and you're a plastic surgeon and all, yeah, they're sort of racking in the, you know, and you know, others that do, you know, do interventional things, you know, they do a whole lot better. But your GPs, your pediatricians, your obstetricians, they're having trouble making a living. And like I say, the federal government just cut their fees. They're fighting it, but it was to go into faculty. So, and then coming out of school. And so we wonder why people don't choose to be a pediatrician or an obstetrician, or how about a family practitioner? It's because they get paid less. We don't seem to value that, the good old, you know, family doctor that you could go to, and hopefully that's changing, but it is a problem.
And last question. So this is a public health issue essentially here. As Georgia has one of the worst gun violence rates in the country, especially for children, what can the legislature do to pass common sense gun safety legislation like the Safe Storage Bill, which has worked for many other states, even in the South? So like I said, public health issue, but not what we've talked about so far.
We could just pass it. I mean, this is not a question for me so much. We could just pass it. The good news is that last session in the House, there was a hearing actually on the kind of safe storage of guns. So that hearing happened. There was no action beyond that hearing out of the committee. There was no vote on that bill to pass. But I mean, this is another area where, for whatever, same as what I was saying before about Medicaid expansion, right? Like those words have become toxic. This also is one of those areas where you just say guns and all of a sudden, like, everybody's like scatters to the corners that they're at, right? There are things that we actually need to be doing, and the truth of the matter is most Georgians, I mean, well beyond 50%, 60-something% of Georgians agree that we do need to be taking some action around the issues of gun violence and safe storage of guns. We do need to be taking action. We just have to do it. And so we've got to figure out how to take away maybe some of the toxicity in the environment and the language that we use, and figure out where we can agree, even if it's just not gonna go as far as anybody might want us to go to start, we gotta start. And then we can do something else, and then do something else, and get it where it really needs to be, but we just gotta start.
Yeah, it's sort of like the tobacco tax, and I didn't get on that. I think our tobacco tax is 37 cents. It's some ridiculous. I think it's under 50 cents. And I thought at first when I came to the legislature we were a tobacco state. We're not. You know, they grow it in North Carolina and we don't. And so I never understood. Now, you know, when I came to the legislature, it was the old red carpet, and they'd had spittoons, and they smoked in the chamber, and you could sort of still smell it. It was gross looking. And it was gross sitting there. And, you know, I could see back then when everybody was smoking. Now, but what happens sometimes, and it has been, I mean, one of the anesthesiologists, Democrat, but a really knowledgeable person, put in, and they went in and put in a bill for $1 something to raise it really high, the minimum tax. Well, when you go to the car, everybody pushes everybody, what? You know, this is just a slippery slope, they'll be back to raise it again. And I think it's sort of the way my side is pretty, I'm a nurse, I hate guns. I don't own a gun, please don't tell anybody if they want to rob me. Just leave me and my dog alone, please, take whatever. And I have been carjacked, so, you know, I've been through this. As I was pumping gas in the car down the way. Thank God they left me alone and didn't do anything to me, and I have a car where I was by the pumps and the driver's side was over there, so they didn't hit me in the head or anything. And so I would vote for reasonable, I mean, I think we're not gonna, okay, let me say this. And I told you, I said, okay, God, I don't want this to happen. But sometimes I have actually thought that it was going to take somebody high up on my side losing a family member because they didn't lock their gun up, or some family didn't do it, before we were ever, am I right? And before we were ever going to move on something. I mean, I don't know what to do. Sandra, one of our members, went to the well the other day to remember her brother who was killed in a gun violence thing, and, you know, called for that. She's a Democrat. And then she went on and made it political, which made it worse. And so she just stopped with that. But sometimes I think it's always, and you hear it, well, if we do that, if we lock them up, that's the camel nose under the tent. They'll be back. You know, if we pass that this year, they'll be back with something else, you know, that might be more restrictive. It's just pretty impressionable. But anyway, now I've said it, I'll probably have half my guys mad at me, you know, but I'm big enough to fight them, so I just say what I feel. That's true.
I do think that sometimes we're looking for big action. No, and there's lots of ways to skin a cat too, right? So, you know, there are other things that could happen that become more policy. We could provide grant monies to law enforcement agencies that actually are training the people who live in their towns on safe storage, where we're still getting the effect and the impact that we want, even if it doesn't look like a big gun safety storage law. You know, there are ways to get to what we're trying to get to. And I'll be honest, I mean, you know, part of what's difficult in this role is we all of us have 2-year terms. So every 2 years, we're back on the ballot. And so you want to have something to show for your 2 years. A lot of the stuff, literally everything, many of the things that we've talked about all morning, honestly, are big, huge, complex problems that are gonna take more than 2 years at a time to actually move forward on. And so some of it is we've gotta have the time, right? We've gotta have the horizon in order to get to the change that we wanna get to, which means that you gotta have the people who are willing to dig into an issue and say, I don't care that I'm not gonna be able to show anything for this in the next 2 years. I'm gonna keep at it, keep at it, keep at it, and then we'll see the change. And so there is that tension, if I'm just being honest, between what can I do today that I need to be doing today, and what do I need to be doing that I know is gonna have long-range impact, but that's gonna take longer to be able to accomplish.
You know, and ideas for bills come from everywhere. I'm sitting here listening to the senator. We're on different sides. I don't know water. That's the kind of district I represent, and I represent my district. And people don't like it, a far right person running against me almost every time. And you know, it's okay. I'm still going to say what I think. I'm sitting there going, okay, you know, I work with a elder abuse task force, and we now give out, and we've gotten grant money and people to help us with it, a little kit, and people get it, and if they have a loved one that wanders, first 24 hours, if you don't find somebody that wanders in 24 hours, they're probably not going to make it. And you get their scent and put it in this sterile thing and keep it, so that if your loved one has wandered, you know, you can give this to the police dog right away, and it's not contaminated with clothes, you know, that kind of stuff. What if some group in where we have most gun violence, you know, raise some money to buy, I don't know how much gun lockers cost if you buy them on, or something to keep it locked, and start it there. You know, sometimes government is not the answer. And if we just could show, or maybe a bill could come forth where we maybe did a trial, a pilot project, where we get enough funding to make those available with police education or something, and found, you know, somebody that would do it. I mean, this is just coming from this, and you go at it that way. Sometimes government just needs to get the hell out of the way and let people, like sitting in this room, help us solve our problems. And I want to thank you for all of you do, because we pass the balls, but we're not the people out there working every day with the people that need our help across our state. And thank you for coming, thank you for asking questions, thank you for putting up with me, and my door's open for the Capitol, we disagree with me, whatever, but I'm there to help. I'm a nurse, nurses help people, it's my passion, I was a doctor. So thank you again for what you do.
And Senator Halpern, it looks like you have one final comment.
One last comment on the gun stuff, because there is a bill this year in the Senate that would, and so sometimes it works to incentivize people too. So there is a bill in the Senate this year that will relieve people of the sales tax if they purchase a lockbox for their gun. So you would be able to purchase the lockboxes and not have to pay sales tax on that purchase. So we're going at it, and we'll see what happens. But I think that, and that's a bill that is being led by a Republican. So I mean, I think that there's opportunity here. And then I'll just close by saying thank you for listening, for your interest in this topic. There's a huge gathering of people, and you all got up so early in the morning to come here for this. I also want to just thank the Healthy Futures for having this every single year, and for bringing together this great group of people to talk about these dynamic issues that are complicated and complex, that are so important, because there is not a Georgian, really, there is not a Georgian who doesn't worry about one sickness bankrupting them, you know? And so we have to talk about these issues, and thank you for having me here to help participate in the conversation. I am in the CLOB 303, but I am available to talk to anybody who wants to. I have no idea what time it is, but I feel like it's getting close to
probably about 5-10 minutes over.
Well, and let me say, I didn't know the senator that well. So it's given me a chance for us to be here together, to talk beforehand, so it helped us too. We've got a great lobbyist back there in the back. I don't usually do morning, because I have to drive my 19 miles. It takes me an hour sometime or more to get here. And I have a dog, and they don't open the daycare center. So the fact that I would just right off the bat say, yes, I'll come for him, talks about how good he is and how much he works for you. So
Thank you.
Yeah, thank you both. And thank you, Senator Watson. So yeah, I know we've been over time. Not sure how far. Thank you all for listening, and thanks again to the legislature.
Please welcome Laura Colbert.
Good morning. I love that the senator and the representative want to stay. You guys are welcome to hang out. Good morning, everyone. I know that a few of our legislative friends will need to get back over to the Capitol building in the next few minutes, but I hope most of you will stay for the second part of our program. We have a really exciting keynote panel for you this morning. But before we get to that, I wanted to make a few comments, say a few things, brag about some of the work that's been going on over the last 12 months, those kinds of things. As our lovely announcers said, I'm Laura Colbert. I'm the Executive Director here at Georgetown for a Healthy Future. And I really love that we get to host Health Care Unscrambled every year. It is a real treat, in part because we get to see all of you. And it's just a really fun way to start all of the legislative sessions. So we get to be in a room with people who care as much about these issues as we do, as our board and staff do. We know that you all are working hard every day, as the representative said, to make Georgians' lives better, to change policies and systems, and to help folks through kind of the bureaucratic day-to-day of some of the systems that we all care and focus on. So I always leave this morning really energized, with a very full heart, and very grateful for all of the people in this room. I am especially grateful this morning for Daniel Wynn on our Georgians for a Healthy Future team. He is largely invisible to a lot of you because he's our administrative assistant, but damn if administrative assistants don't make the world go round. So if everyone could give Daniel a round of applause. Thank you, and thanks to the entire Georgians for a Healthy Future staff team. And our board, some of whom have and are going to be on the stage today. Just a really fantastic team. All of that to say, this morning is always wonderful and great, and it will continue to be wonderful and great. But usually sometime, during sessions, sometimes I can get all the way through session and I get to the summer and then I start getting like a little down. My energy starts to like fade a little bit. This work is hard, this work is grueling. Any of you have that experience? I see a lot of nodding heads. That was more than I expected. Same. Towards the middle of the year, I kind of start to like feel like I need a little boost, a little energized. And this past summer, I was having lunch with a former colleague of mine. She has since retired, but still kind of stays up to date with all of the issues that we work on. Many of you probably know her. We were at the time talking about the closure of the Atlanta Medical Center and what that meant for our communities, and I was feeling very down because I didn't feel like GHF had the resources to really dedicate to the issue, to looking at hospital accountability and making sure folks had access to care, but I also felt like the issue couldn't be ignored. And she very kindly looked at me in the middle of this conversation and said, "You all are doing good work. It is important that you are there, and you are doing enough." And as you can tell, that still gets me. And it has really buoyed me in the months since. And she wasn't talking about just me and just GHF. She was talking about all of us as an advocacy community. It is important that we are here, and the work we are doing is important and it is moving the needle. So I wanted to pass that message along this morning because I think we often don't hear that enough, that your work matters, that you're making a difference. So whether you are an advocate, a nurse, a peer, a doctor, somebody in our government agencies doing the work every day, you are making a difference and your work is important and it matters that you are there doing it. And I think as I was kind of preparing my remarks for today, I was looking back at the prior year, and I think we have some really excellent examples from 2023 that kind of illustrate how powerful this community is and all of the people that we work with who aren't here this morning. So I'm just going to list a few examples, and this is my short list. I pared it down, so bear with me. So as of January 1st, Medicaid's 5-year waiting period for lawful permanent residence has been lifted. So that means some of our most marginalized folks here in the state, children and pregnant women who are immigrants, are able to get access to care and health coverage in Georgia. That's a huge win, and congratulations to everybody who worked on that. Medicaid also has to cover gender-affirming care for covered Georgians, thanks to a successful lawsuit against our state. So exciting expansion of benefits. That change would be even more meaningful if we close the coverage gap and have more adults, especially transgender adults, covered by Medicaid care in our state. Georgia's all-payer claims database, which was authorized by a 2020 law, collected its first batch of data this year, so we will soon have analyses that help us look at uneven cost and outcomes of care across the state. It's going to help us inform so much of our work in the years to come, and getting that up and running is a massive lift. So very excited about the all-payer claims database. I know I'm one of only a few in this room that is excited by that. Governor Kemp turned away from his non-marketplace waiver and pivoted to a state-based marketplace, due in part to many of the public comments that all of you issued and mobilized since 2019. And so we will see the full rollout of that state-based marketplace later this year. And as of yesterday, we have 1.2 million Georgians enrolled in ACA coverage in this state. That's a 50% increase over last year's enrollment record, so just a giant, giant win. And we still have a few more days to go in the open enrollment period. And then finally, the heroic work of enrollment assisters, health insurance navigators, social workers, community health workers, and all of the other helpers who are helping families through their Medicaid redeterminations. Our unwinding is not done yet. Georgia's unwinding will go through May, but we would be in a far worse position without these folks around the state helping families every day get through that paperwork and get through that system. So thank you to all of them and the amazing work that they are doing one family at a time. And I'll specifically call out Deanna and Angelica on our team for playing that role of being our enrollment assisters on the Georgians for a Healthy Future team. So while we still have a lot of issues here in Georgia to solve, you can see that every year we chip away at it. Every year we kind of make progress down the road. And that kind of brings to mind an analogy that I think, is Carol Maddox in the room? I think I saw her come in this morning. There's Carol, hi. Carol shared at one of our health advocates meetings in recent years, and I hope you don't mind me sharing, but Carol illustrated advocacy as kind of water dripping out of rock. So we are here to really drip, 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 and on an individual day or maybe an individual year, it doesn't look like that rock changes all that much, but over the years, the water erodes away the rock, and maybe that rock becomes a creek bed or a river, or over years, the Grand Canyon. And so I can see from our 2023 wins that we are dripping. We are becoming a creek bed. And I think Medicaid expansion is a nice illustration of this. For the first time since 2012, probably, we have Republican state leaders leading conversations about Medicaid expansion in our state. As many of you here, and I know our entire Georgians for a Healthy Future team have dripped, and in a lot of cases hammered on this issue for more than a decade. And some folks have even told me that Georgia will never expand Medicaid, and I'm just really happy that we continue to drip on that rock. I'm not going to count our chickens before they hatch. We don't have expansion yet, but it's coming. So, because all of us have continued to keep at it every day, and have continued this work moving forward. So thank you for being a partner to the Georgians for a Healthy Future team. Thank you for your dedication to this work and everything that you do, whether that is being at the Capitol, whether that is collecting stories, whether that is donating to organizations who are on the ground every day. Thank you so much. And this morning, we have a great keynote panel who is going to kind of help us think through how we can continue dripping and changing the policies that stand in the way of a healthy, equitable future for our state. So I think you'll find them as inspiring and exciting as I do. I know a lot of you like to get a little bit in the policy weeds, and I think we'll get a chance to do that here in the second half of the program. So I'd like to invite Joan Alker and Alex Briscoe up to the stage as I introduce them. Dr. Joan Alker is the Executive Director at Georgetown University's Center for Children and Families. She is a nationally recognized expert on Medicaid and the Children's Health Insurance Program, which we call Peach Care. Joan has testified before Congress, served on expert advisory panels to the federal government, and is regularly quoted in national media. This is her second time at Health Care Unscrambled, so welcome back. And then we also have Dr. Alex Briscoe, who is the principal at the California Children's Trust. Alex is a mental health practitioner specializing in adolescent services and youth development. Alex has led several programs and health systems in California, and he has served on the Kaiser Commission on Medicaid and the Uninsured. And he now specializes in Medicaid policy administration, emergency services, youth voice, and crisis counseling, as well as safety net design and administration. So please welcome Joan and Alex, and thank you both for being here this morning. Okay, I'm going to transition over. We also have table tents. 1 second. Okay, morning. How is everybody?
Can you all hear me?
Yeah.
Okay. I usually don't have trouble projecting, but I am on a travel palooza and the end of a little something, so I'm gonna keep my mask on if everybody can hear me.
Great, that works.
Okay.
Good morning.
Good morning. How's it going?
Hi. So we spent a lot of time this morning talking about Medicaid and health insurance. As policy and advocacy professionals, why do we spend so much time talking about health coverage and in particular Medicaid?
Well, I will jump in on that. I've been working on Medicaid now for about 25 years. And I will just say that over that time period, it has become a lot more popular. It always tested well, it always polled really well, but to be honest, I think 25 years ago when you asked people, do you like Medicaid, I think they heard Medicare, and they said yes. But now I truly think that it is very popular. And it actually covers half of the children in this country, which is an absolutely astounding fact. We all know the other key roles it plays. It is the leading payer for long-term care, it's the leading payer for mental health services, and many, many things that Medicaid does in our healthcare system. And its role has only been cemented as really the backbone of our health coverage system, filling in for where private insurance is either too costly or it's not comprehensive enough or it's just not meeting the needs of certain folks.
Yeah, what Joan said. Medicaid is the tie that binds child-serving systems. It's not just a health insurance product. It funds services in special education, in juvenile justice, in foster care, in early childhood. So it's an essential glue to build a more just and equitable system for children and their families.
Thank you. There's been a lot of changes, there's a lot of movement in the Medicaid landscape these days, so I wonder if you two can help us kind of walk through what are those changes? What do we need to know about them? How are they? Well, we'll dig into the others in a second.
Yeah, so first of all, I think everybody knows there's not a ton going on in Congress right now in terms of sort of functional legislating, and that's been true for a while. But despite that, we have a historic event going on in Medicaid, as all of you know. We call it the Medicaid unwinding. I'm not sure that's really the best thing to call it. I had a friend visiting recently from the UK, and she said, well, that sounds very benign. And I was like, oh, that's true. That does sound very benign. And we were extremely worried about Medicaid unwinding. We've been worried at the Center for Children and Families for quite a while now. My colleague Tricia Brooks and I wrote a report in February 2022 and projected, and we were like, this is like uncharted territory here, people. We don't know what's gonna happen, but we're really worried, especially for children, most of whom will remain eligible for Medicaid. But we had projected that as many as 6.7 million children could have a gap in coverage in this process. That is a huge number. Last year we had 4 million uninsured children in the United States. So we projected this and we said, look, we don't know if this is a good number. This is, you know, this has never happened before, but this is how big we think it could be. So I sit here today, we're almost halfway through. We have a national tracker that is tracking net Medicaid decline, and I'll talk more about that. I'm sorry to say we're at 3.3 million.
What was the question again?
What are some of the changes happening in Medicaid right now?
Well, per the great conversation in the previous panel about 1013, we are having a national reckoning about the social and emotional health of children. So if you know a kid or you ever were a kid, you know this is a really tough time to be a child. And what the data is showing us is that we are literally seeing a doubling of inpatient admissions for self-injury. Literally, like, we have to ask ourselves this question as a nation: what will we do when twice as many of our children try to kill themselves? And Medicaid is an essential strategy to address this unprecedented challenge. So the changes and sort of the reimagining of the behavioral health side of children's Medicaid is perhaps the most exciting thing that's happening in the Medicaid space from my perspective, and it's a challenge we're just beginning to embrace in Georgia.
That's right. So I want to dig into a few of the changes in a little more detail. Joan, I'm going to come back to you on the unwinding, and I hope you'll also touch on pathways a little bit.
Sure. So, you know, I spent a lot of time actually in the South. For whatever reason, that tends to be where I'm just very interested to see what's going on, and really, you know, I take my hat off to all of you in this room working in public service, private, nonprofit. You're working in a tough environment. And as Laura, I think, beautifully laid out, you're making progress. You're making progress. And I'm going to start by talking about Medicaid expansion and pathways. And I do believe that all states in this country will do Medicaid expansion. I'm really sure about that. We're going to get there. It's just a question of when. And we're in a little bit of a moment now, a little bit of a momentum moment. You know, I've been watching this issue really closely. About 7 years ago, I was so obsessed with Medicaid expansion that my husband made me a birthday cake, and he's a very good baker, and he did a map of the United States, and he had all the states that had Medicaid expansion and those that don't on the cake. And I do a ton of work in Florida. I'm very obsessed with Florida, and so I cut off Florida, and I have it in my freezer. And I'm gonna eat it when Florida expands. It looks pretty gross, but I'm gonna eat a bite. So everyone's gonna get there. Fascinating, you know, we've looked very closely at the Pathways program. We've written issue briefs about it. Come to our website, read them. I personally worked on Section 1115 waivers a lot. Here is my one sentence summary for you of Pathways, and I'm sorry to be harsh. I realized on the plane when I was coming here, I was like, oh, I try to have positive things to say. Unfortunately, I have a lot of sort of negative things to say about where Georgia's at. Pathways, I described from day one as being fiscally foolish and anti-family. The way the program is structured, it's near impossible for a parent or a caregiver to get in. But the fiscally foolish, we know that it's operating at regular match, not the enhanced 90% match. We know Congress has put extra, $1 billion on the table Georgia could have. But quite honestly, now that we see that the enrollment of Pathways is just 2,000 and change, at this time, somebody, investigative journalists, and if you hear, please do a FOIA, get the litigation costs, because this program has been under litigation, get the administrative costs of all the time negotiating this Section 15 waiver. I can't tell you how much time federal officials have spent on this, state officials must have spent on negotiating this for years now, as well as leaving all that match on the table. What is your per capita cost for 2,000 people? It is darn high. This is unfortunately for a political ploy, essentially, the governor made. This is one of the most foolish uses of state taxpayer dollars I've ever seen. And I'm sorry to sound so harsh. I try not to, but that is the reality. I have not, with one exception that I won't diverge into, this is just an absolutely ridiculous waste of money when nobody's getting coverage and the cost per person just must be astronomical. So I think that's becoming very clear. Secondly, we have North Carolina. And when you look at what happened, okay, Georgia's been enrolling for 3-4 months, got a couple thousand people. North Carolina got almost 300,000 people on the first day, okay? So it's a pretty stark contrast. So I think the time is coming. I'm feeling momentum around the country. I think that's very exciting. So I'm gonna stop there. I'll say more about unwinding later, but let me give Alex a chance to jump in.
Great. And Alex, I know you wanted to talk a little bit about the CMO procurement and what that could mean for changes in Georgia's Medicaid program.
Yeah, the truth of Medicaid is that it has become a managed care product. So like, when I ran an emergency department in the 90s, 90% of children were on fee-for-service. And today, almost all kids are in a managed care plan. And that's a really difficult challenge for those of you who are trying to do advocacy and system building, because health plans work in what we call a distributed risk model. Think of it like an umbrella. Everyone under the umbrella gets a per member per month payment, and the plan distributes risk. They take those dollars and pay for the people who need care. And kids don't fit that model well, because who costs? High-cost adults. So the question we have now in Medicaid is, what will we do to ensure managed care meets its obligation to provide care and support for kids when traditional medical model reimbursement isn't the most effective way to do so? And so Georgia is taking on this moment to reprocure its managed care products, and you all have a last mile challenge, which is managed care plans are all bidding against each other to tell you what they're going to do in your state to make it better. And you have the responsibility as a public system and advocates to both name the things most important to you and then enforce them over time. So you're in a moment of transparency and accountability for kids in care. And it's very difficult to do because traditionally plans pay claims. And your interest for kids is on things like prevention, on things like immunizations, on things like well child visits, on things like getting access to mental health support in their schools. Things that health plans aren't good at and haven't done a lot of. So the challenge before you right now is to leverage this moment of reprocurement and ask for more and better from the plans and find a way to measure it.
Thank you. That kind of gets us to our next question. As you heard from some of our legislative panels this morning, there's a lot of discussion, belief that Medicaid doesn't actually improve health outcomes. How do you guys respond to that? Are there ways that Medicaid and other forms of health insurance could move the needle better?
Yeah, so a couple things I want to say to that. First is that the opposite, I don't know if opposite is the right word, or it's inverse, or I just used geometry was too long ago for me, but not having insurance is bad for your health. That is well proven. So, is having insurance enough? No. But I always say, the way our healthcare system is structured in the United States, having insurance is the price of admission. And how good a show are you going to see? Let's work on that. But let's make sure everybody has a ticket, and then we'll try to make sure they see a good show.
Yeah, I really enjoyed hearing the previous panel, but I don't know what to say other than the last comment about Medicaid not being the same as not having Medicaid flies in the face of 60 years of policy and data and research. So I'm very, very respectful.
Alice, can you speak a little bit to kind of the public behavioral health system? And I feel like you've said something to me about kind of millions of dollars spent on kids each year that really should be covered by kind of managed care and Medicaid.
Yeah, Georgia's not alone here, right? You have this legacy public health department, the Department of Behavioral Health and Developmental Disability. And many, many states have this type of challenge, which is a historical entity who has been your sort of child system of care. But the centricity of the plans has emerged without careful consideration of who DBHDD is, what they do, and what their role is. So you've ended up with role confusion. And that's not a surprise to anybody. Systems change is hard. And so you're now in a moment of thinking about how to reimagine your service boards, how to actually fundably, how to sustain your investment that you've made in schools. And DBHDD is being tasked with writing a system of care plan where they don't actually control the money that funds the priorities that they are leading. Are you with me? So we're sort of in a moment right now where we have to reimagine the role of the essential actors in your space and their articulation to managed care. But what Laura's asking is, Medicaid is a pot of gold in DC. You get $1 if you put up $1. And you could distill my career to hunting for dollars to match. Like, when you lead a health system, you're always looking for a naked, non-federal dollar. And Georgia is spending a lot of dollars through DBHDD that it is not securing the federal match for, and there is real opportunity to generate additional revenue. I mean, one example just from the previous panel, if you do bring your tobacco tax up to national averages and you do generate $500 million of new revenue, you should match it and make it over $1 billion in reimbursement. And so those are the opportunities before Georgia.
Great, thank you. I do want to step back to the unwinding for a little bit, because that has kind of been maybe the earthquake in Georgia's Medicaid system this year. Joan, can you talk a little bit about what's happening, who's being impacted, and what are we learning from it?
Yeah, I was looking at the data that we have to get ready for this conversation. And by the way, we have a lot of comparative data on our website, so we have a wonderful, wonderful team working on it. So we don't have a lot of data from Georgia, so that's one area where unfortunately Georgia has been a poor performer. They have not released very much data. Every state is required to report certain data to the federal government. A lot of states are going above and beyond that, and in fact, we have more data from Texas and Florida, because I spent a lot of time looking at Texas, Florida, and Georgia, because I knew those would be the 3 big states for children. And we're seeing a lot of problems. I'll tell you, Texas is ground zero. We've got over 1 million children have been disenrolled from Medicaid in Texas alone. It's really frightening. So unfortunately, though, we don't have a ton of data about Georgia. What data that we have is very concerning. And so while we don't have a lot of breakdowns for Georgia, we have some early data that I know a reporter had gotten. Children were very impacted. But we know who the population is. And this is something that we tried very hard at CCF to highlight for folks before the unwinding started, right? You're a non-expansion state. So by definition, you're not covering a lot of adults or adults without children. You are covering primarily children, new mothers, very poor parents, mostly women. And that's who's losing coverage. And many of those people, now some of the children who are aging out, yes, they're falling in the coverage gap because you're non-expansion state. But this isn't about not expanding Medicaid. That's a whole another issue, which, as previously established, I'm very passionate about. But this is about children, 3/4 of whom should remain eligible for Medicaid. And they're losing coverage not because they're not eligible, they're losing coverage for procedural reasons. Procedural reasons means the family is not completing the process for whatever reason. And there's many reasons for that. You know, it starts at day one. Did they even get the letter? Was the letter confusing? Could they get help? How was the customer service? You know, there's many, many reasons. You know, we learned over the summer that there was a glitch in many states' computers where they were assessing eligibility wrong. They were assessing based on the whole family, not the individual members of the family. We've been very worried this kind of problem would happen because parents are eligible at much lower levels than their children. And this was exactly the kind of thing we were worried about, children getting caught up in those kinds of mistakes. And unfortunately, our worries have been, honestly, it's worse than we expected, and we had pretty low expectations. So I do think there is a silver lining here. There's lemonade to be made out of these lemons, but I want to just stress, this is about, in Georgia, this is about children who are still eligible, very poor parents, some of whom won't, but it's about children who are eligible losing coverage. And you already had a very high uninsured rate prior to the pandemic. You know, everybody knows Georgia hasn't expanded Medicaid. You obviously have a high uninsured rate for adults. Less well known is that you have a very high child uninsured rate. Before the pandemic, I don't know if this is well known to everybody here, Georgia's child uninsured rate, 6.2%, was twice as high as Alabama's, 3.1%. Higher than Mississippi's. That's going to go up because of your unwinding. So this is a problem, and there's going to have to be a lot of effort to get those kids back. But let's seize the moment, and this is where I'm going to get to the lemonade part. This has been, you know, a really shocking event for some people. It's for those who work in the weeds of Medicaid eligibility. No, we're not all particularly surprised, but it's got a lot of public attention, and people are like, wow, this is a really messed up system. There are some states who took advantage of the continuous coverage in the pandemic, and all of us have been talking for some time about how important continuous coverage is, and I'm going to come back to that. States that have established new frontiers, and Oregon is leading the way, but it's not just coastal states. Ohio is also doing a waiver to do 0 to 3 continuous eligibility. So the baby is born, they're just covered till they're 3, till they're 5, in California till they're 6. We're over 10 states now pursuing this policy. We've been talking about this policy for 15 years and nobody did it. Now we've seen in the last 12 months, more than 10 states are moving forward, and it's very exciting. Some years ago we wrote a paper about we should live in a country, obviously we need universal coverage. But like everybody knows Medicare, you're 65, you get Medicare, right? Let's live in a country where every baby leaves the hospital with health insurance. This should be a thing. No baby should leave the hospital without health insurance. And then in the parent notes, that's just part of the paperwork, you know, they can make you fill out a lot of paperwork when you're in hospital, have a baby. I remember that a while ago. So, and then let's cover them 0 to 6 in those critical early childhood years, so there's no gap in coverage. And then let's just check their coverage every year at school, when you enroll in school, right? We could solve this problem. We don't have that many uninsured children. They're not even that expensive to cover. And I really can see that day now. You know, we've been talking about this for a while, but I can see that day now.
It's coming.
Alex, anything about it?
Every one of those kids who's eligible but not enrolled falls into DBHDD's bucket. They gotta pay 100% of the cost of them. You as taxpayers lose. Every one of those kids who's not eligible, who falls off, or is eligible but not enrolled, who interacts with juvenile justice or foster care system, comes out of your pocket. So it's not even like a politics thing. It's just a good business thing. Like, don't pay for stuff you don't have to pay for.
Speaking of good business, let's talk a little bit about some of the creative ways that the California Children's Trust and the Public Works Alliance have kind of proposed to rethink some of how we do Medicaid and health insurance and getting the most out of it. And I think we have a slide that has your framework up on it, so yeah, there we go. I don't know if you want to touch on all of them or just kind of briefly go over kind of what are some of the approaches you guys have been considering.
That's a lot of words, but so just think for a second. When you took your baby to the doctor when they were little, did they have to have measles to get the vaccination? Did they have to have mumps? Did they have to have rubella? No. Like, one of the most successful things we've done in the American healthcare system is the childhood immunization program. But kids didn't have to be sick to get that immunization. Why do we require a diagnosis for kids to get access to a mental health service? Particularly, so that's not consistent with federal law to require a diagnosis. And also, kids didn't just become twice as pathological. Okay? Do you remember the data I said earlier that literally twice as the number of children are now being admitted for self-injury? It's actually not them, it's us. We've created a toxic culture for children. We now need to teach them how to live in it. And if we diagnose them, we pathologize them. And there are kids, like, I believe in beds, I believe in meds, you guys need those too, okay? But at the heart of the youth mental health crisis is something happening within people that has very little to do with individual psychopathology and everything to do with navigating a very difficult time to be a young person. So we've got to change the access criteria. And the ones we're seeing start to pop up in states is some of the work that Dr. Nadine Burke-Harris did around the Adverse Child Experience Survey. Like, can we agree that kids who are housing unstable or food insecure or who had really bad things happen to them as a kid need support? So reimagining access criteria is the sort of first one. And then the other one I'll reference just from this long list is where services happen. So for little kids 0 to 5, it's obviously pediatric primary care. But in pediatric primary care, we are so focused on the young person, we forget the caregiver. And so there's actually some extraordinary work happening here through Gears, Callan Wells. You all have done some very special work, crosswalking child-parent psychotherapy to reimbursement practice. You've got a last mile problem, you got to get it into pediatric primary care, so there's some implementation issues. But we need to do caregiver mental health when they take their babies to the doctor, because babies don't go to the doctor by themselves. But the way Medicaid is currently constructed, you reimburse for an identified patient and a diagnosis. Mom is not the identified patient, and what diagnosis is, hey, it's hard to be poor with a little baby. So reimagining access criteria where it happens, which is pediatric primary care for kids 0 to 5, and schools, obviously, for kids 8 to 21. And you all, again, have some really important groundwork laid through the extraordinary work of your school-based health centers and the APEX program, but you got a last mile problem. Both your commercial plans and your Medi-Cal managed care plans, your CMOs, aren't effectively reimbursing those services, and they're currently significantly subsidized by one-time dollars. So you have to formally articulate your schools to healthcare payer networks, making them just as essential as a doctor's office and ambulance hospital. Like, literally, where we will transform children's mental health is not in the doctor's office. because kids 8 to 18 have the lowest rate of primary care utilization of any demographic group. So to wrap here, decolonize your mind a little. Mental health is not a response to pathology, it's a support for healthy development. It's something that most kids should get. And not because they have a diagnosis, but because it's tough being a kid in this culture. And where we're going to do the work is pediatric primary care in schools.
I'm glad you started, kind of got us into talking about schools. Two of the strategies in the framework are kind of centering schools and health systems, which you just talked about, and then also expanding the provider class. So thinking about who else can deliver the services. How do those strategies work together? And then, Joan, I know you guys have done some thinking also about like how can a school-centered approach help bridge disparity gaps and improve health outcomes? So, Alex, do you want to start?
Yeah, I think this is one of the most exciting aspects of the entire reform landscape. So there's a term we have in healthcare called empanelment. If you're a doctor or a provider, you know what it means. It means how many patients per provider. And so even if you wanted to give every kid who needed a therapist, they don't exist. It's not gonna happen. Like, there's not enough. So it's forcing us to reimagine who does the work and where it happens. So there are Medicaid programs across the nation. And you guys are actually one of them, doing really interesting work here, adding new provider types to the reimbursable classes who are eligible to do the work. So examples are, your new state plan amendment has community health workers in it. You have another brand new state plan amendment that creates a new provider class called behavioral health technicians. You're looking at a new doula benefit, and then there's these things called wellness coaches. So in one way, like, what's happening in mental health is something that happened in primary care back in the 80s and 90s. Like, when we knew we didn't have enough primary care physicians, what did we do? We created NPs and PAs, and LVNs and MAs, and we expanded who could do the work. But then we also shifted who did what, when, and where, and we came up with this idea of working at the top of your license. So when you think of the future of youth mental health, think schools, primary care, not a diagnosis, and a new type of provider interacting with a young person all the time, and a therapist only when they need it.
Yeah, that was great. You know, I have to say it's great being on a panel where I disagree with everything. I agree with everything Alex says, and that's making my life easy. So I think there's a ton of interest at the federal level about how to facilitate access to both community health workers and also school-based reimbursement, the two topics you mentioned. There's new guidance, there's a lot of new opportunities. I think they're not particularly well known. We have a couple of issue briefs on this that Dwyer has written if folks are interested, because there's sort of somewhat obscure things that have passed in federal law. So please do let us know if we can help provide some more resources. And then before we finish, I do want to mention the new federal law that is good news, trying to be more positive. So as a consequence of the Consolidated Appropriations Act, which passed the end of 2022, and that's sort of kicked off the unwinding, but in recognition of how important continuous coverage is for children, Congress did pass mandatory 12-month continuous eligibility in Medicaid and CHIP. I believe Georgia had neither of those in place. States, about half the states had each one. Doesn't matter where you live now. So that means, and this is really important, because families are gonna have to know about this. Once your child is enrolled, you're on for the whole year, no questions asked. So it's kind of like a mini version of what we just saw during the pandemic, but it's a policy that we think is really important to minimize churn. So now we have a federal mandate, 12 months everywhere in the country. That's going to be a change for Georgia in the right direction. That is going to help to reduce our uninsured rate. Let's build on that and push for 0 to 3, 0 to 6. But that alone is a really important policy, and people need to be aware of it. It just came into effect January 1st. Along with that, CMS issued guidance, and it's just a frequently asked question, so a little obscure, but my colleague Edwin Park wrote a great blog about this on our website. Your CHIP program can no longer charge enforceable premiums. Okay, I can tell you most people are not aware of this. So what CMS said, and Georgia does have premiums in your CHIP program. I know the governor froze them during the pandemic, which was good. But I imagine that freeze is being lifted now. So families may have to pay a premium in the first month to enroll the first time, or an enrollment fee, that's permitted. But in months 2 through 12, because remember now we've got 12-month continuous in Medicaid CHIP. So in CHIP, okay, the family may have to pay a premium in month 1. They don't, you could say you have to pay a premium in months 2 through 12, but if they don't pay it, you cannot kick the child off. So this is, I mean, this is a big change in real life, right? It's the absolute right interpretation by CMS, because that is the intent of the law, is that when a child is determined eligible for Medicaid or CHIP, they get it for 12 months, no questions asked, unless they move out of state. But that is the law now. As of January 1st, premium structure is going to have to change. I think it's very important to be aware of this, because I'm a little worried that some states may not tell families, particularly well or often, that if they don't pay the premium, their child's going to retain coverage. States need to rethink their CHIP structure in general, because we're also expecting federal regulations to be finalized, which will, if they remain the same as the proposed regulations, will prohibit waiting periods in CHIP and lockouts for non-payment of premiums. So it's really not going to make sense to have premiums anymore. And I just want to point out, CHIP is a program that passed in 1997. So there's a lot of things about it that are outdated, right? Like, why would we have a waiting period for CHIP? Congress put that in 1997 because they thought, oh, all these employers are going to drop coverage if we don't have this waiting period. Didn't turn out to be true anyway, but hello, the Affordable Care Act passed since then, which is, you know, a whole new landscape, much more impactful on employer behavior. So CHIP has to be modernized. So they're going to get rid of all of those things, I hope, in this regulation. And also, by the way, because there's enhanced ACA subsidies, which are helping the great enrollment numbers, children are paying premiums and their parents are not. That's not right. Children, because you're below 250, you're not, even if $0, Laura knows better than me, plan on the marketplace, but you often are paying premiums in CHIP. The children are, that's not right. So this is all change happening right now, and again, we've got a lot of stuff on our website, but it's really, really important for families to understand. We've lost so many families, we got to get them back, but they're going to come back to a better CHIP program.
They really are. I did not know that about the premiums, so I'm glad I wrote that down. I'm sure Deanna, Angelica, and all of the other enrollment assisters and helpers also wrote that down this morning. One note, I want to jump back to the question about Medicaid enrollment that I think somebody asked our legislative panel earlier. There is a program that helps certify community members, well, yes, some community members to be like Medicaid enrollment assisters. It's called the Gateway Community Partner Program. It's kind of hard to find on the DFACS website. If you can find Panetta, Deanna, Angelica, or myself this morning, we'll see if we can send out or get you a link, or maybe we can send that in the recap email, but did want to make sure to note that. Alex, a lot of the folks in this room worked on Georgia's behavioral health parenting law. It took all of us to get it over the finish line. Going back to the kind of framework of strategies that you were looking at around Medicaid, when we think about removing diagnosis as a prerequisite for care in Medicaid, how would that expand the parenting law and the benefits of that? What would that look like for a kid?
Well, first, I think the parity law does some really important foundational work. So congratulations and kudos to all of you who worked on it. It's a really good beginning. But there's some incremental and important next steps that have to happen. So to specifically answer your question, if you remove diagnosis and added the Z codes to your reimbursable list of codes, and you ensured that they paid a rate that the providers would accept. So you not only have too narrow a set of diagnostic criteria, your rates, as you well know, 16 to 51%, are way too low for providers to build business models. So they're all requiring on some form of subsidy to serve kids. So what this might look like is a kid in your public school would be walking down the hallway one day, and someone would say, yo, what's up, friend? Trey was amazing last night, wasn't he? And this young person would say, yeah, and that person would start a relationship. And the next day, they'd walk past him in the hallway, and they'd notice that he was wearing the same clothes. And he'd be like, hey, man, what's up? You all right? Everything good? And the guy say, yeah, I'm doing okay, and hopefully that person is good at building trust and alliance, and might, in that conversation, the next one, find out that that young person is sleeping in the car. And that young person could then get referred to someone at that school who is a trained clinician, who could then start talking to that young person about the challenges of finding meaning and connection when you don't have your basic needs met. And that is what access to care in a reimagined access criteria looks like, with an expanded provider type, not requiring diagnosis to get in the front door, and delivered in a different place.
Awesome. We are going to open it up for audience questions. So I believe we have 2 microphones that are going to be available in the room for folks to ask. And while we kind of wait on folks to raise their hand, I'm going to ask one other question that I didn't have planned, so hopefully you guys are ready. There are a few states that have started being approved for waivers that allow Medicaid to pay for things like housing and food. Can you guys talk a little bit about that and like what that means for kids and families?
Yeah, I love this question. If you buy what I'm selling, that individual psychopathology isn't what's hurting kids, that it's broader social context, and that if you're never going to treat away housing instability and food insecurity, then these social needs programs are super interesting, and states are going about it a different way. I'm sure Joan can get into some of the details. I've looked at Oregon and Arizona and North Carolina. Some of them are doing subcaps for social needs, meaning taking a little bit of the capitated payment each member gets and giving it to a not-for-profit to help families with housing and food security and employment. So there's others that are doing sticks or carrots, sort of incentives, or sticks for if you don't spend enough of your money on certain types of things. So I think there's some creativity emerging across the nation about how to fund the social supports, or what we call the social determinants of health, that are essential for health plans to improve health outcomes, because just more doctors isn't always the answer. I'm not trying to say that doesn't matter. So I'll stop there. I think subcap, incentives, sanctions seems to be the way that managed care plans are going.
So there is a lot of action in this area. I think sort of most commonly referred to as social determinants of health in this section 1115 space, which are, as you all know, ways in which the federal government, the secretary has discretion to approve some additional spending and some things that don't comply with the normal Medicaid rules. So the Biden administration has been very interested. I think they have fairly, it's all a little bit fuzzy, but they put out some guidance, and when you look at some of the waivers they've approved in California and other places, you can kind of see where they're drawing the line. I think the tension is that Medicaid is a healthcare program, and it fundamentally is about access to healthcare. And while it's really great to have the Section 1115 option to allow states to experiment, and that's what Section 1115 is about. It's supposed to be trying new things and looking at these kinds of issues. It's interesting. I feel like my first job, I worked with homeless people. I worked at National Coalition for the Homeless and homeless families, We talked about the same thing then, that was a long time ago. It was like, we have to have housing, and we have to have services with the housing. You know, it's kind of like, I know we make up all these fancy words, but it's like, yeah, So anyway, there's a little bit of tension about how far can Medicaid go to pay for these things, which are fundamentally not health care, but I think the administration has done, you know, a pretty good job of thinking that through. There's a lot of action about justice-involved youth, a lot of thinking going on there. And I guess to just kind of wrap it all back to one of the points Alex made earlier, which I totally agree with, you know, I think we want to really explore, you know, push the envelope here. At the same time, I very much worry about managed care plans getting money to do things without transparency and accountability. And back to the earlier point that Alex made, couldn't agree more. You know, in addition to making sure that everybody has coverage and we don't have gaps, we've got to get under the hood of these managed care plans and have more transparency and accountability for the taxpayer dollars. That's who's delivering the care, and there's just not enough oversight. So we've got to address that tension. Thank you.
What questions do we have? We've got a hand over here and a hand over here. So whoever gets a microphone first, it's a race. Here we go. Jana has a mic for Stan.
I really appreciate what you said, but I can't imagine any insurance law or EPSDT definition of medical necessity that does not include the word diagnosis. It strikes me it might be easier to redefine like a housing or food. It's a diagnostic condition than it would be to change 500 laws at the federal or state level. But I'm curious to know whether you're watching any state that is, or Congress is actually dealing with the issue. I mean, EPSDT is a good place to start. There's a new lawsuit here trying to enforce that. We've always talked about screening and not talked about treatment. I mean, that's the essence of the problem here. If you point us to something written or some experiences in some other places where these top new things we're accenting are actually happening, so we can learn from them.
Yeah, thanks for that question. So I'm not sure if folks are tracking, but medical necessity is this term. That's basically the gatekeeper. Like, a service has to be medically necessary for it to get paid for. And so we're not actually changing, that. What we're saying is, we use the term access criteria. Like, we're redefining what qualifies as medically necessary by leveraging the impact of the adverse child experience study. So showing that kids who were exposed to trauma as children have higher rates of congestive heart failure and asthma and cancer. And so we basically argued to our state benefits division, and have now done so in a couple other states, that for children, the definition of medical necessity is unique. It's not the same as for adults. There was an amendment to the Social Security Act in 1967 that said kids should get everything they need to grow up, whether it's listed in the state plan or not. So there is a chance to play on the flexibility of that. And that was what I was sort of saying about immunizations, that we think you can't change the fact that it has to be medically necessary, but you can, in your state plan and through your state benefits division, change the access criteria that define medical necessity. Are you with me? Because it's a little bit of a play on words. There's nobody in this room who has billed more adjustment disorder not otherwise specified than me. Right? Working in safety net settings for a lot of years, you know, I'd say about 20% of the kids I've served were mentally ill. And 80% were dealing with just really bad stuff in their lives, like just tough stuff. And we've had to cheat on that for many years, or play in the gray. And what we're trying to now do is create an access criteria mechanism that the feds will acknowledge, and again, largely using the ACEs science.
Can you take it to Millman or Interpol and really affect other insurance?
Yeah, the place we did it is, and we didn't need a waiver, believe it or not, is there's something called the family therapy benefit, which was the first benefit in the nation to qualify children and families for access to care based on these social determinants and adverse child experiences. So that's, and what we discovered is we didn't need a waiver or federal approval, that we basically just negotiated with our benefits division. Because of the EPSDT flexibility, managed care plans could choose to add it based on this kind of federal obligation they have to ensure that kids get what they need. So while there's all sorts of problems with kids in the managed care model that I was trying to talk about earlier, like kids in a distributed risk, what does EPSDT mean in a managed care environment? There's also opportunity. So I'll end with this. My kids tell me uninvited counsel is the worst kind, but I'll offer some. Be more like a laser beam and less like a fluorescent light bulb with the managed care plans. Pick a very small number of specific things that matter to you, and you can change them every year. But most importantly, in your world, I would suggest you have some foundational work that has happened in 0 to 5 in early childhood. We want to know how many claims are being paid in pediatric primary care for the work that Gears and Callan did and DBHDD did, crosswalking child-parent psychotherapy to your benefits. Like, you want to know, all that work we did it matter? Is money flowing? You want to know each one of these new managed care plans. You want to know how much did they pay for in schools? And are Z codes added? And I would begin with something like that, very small and narrow dashboard. Each plan has to report on the same model. And I actually think in the conversations we have with DCH that there's a lot of openness to that type of approach.
Thanks, Dan. I think we have a question over here.
I have a question about the Medicare unwinding and kids being affected. And I think one of you or the previous panel said almost all of them are covered by managed care organizations. To me, that means managed care organizations are losing money. Do you know what are they doing to solve this problem? Because it affects their bottom line. They're not going to get paid for those kids, whether the kids show up in the clinic or not.
Yeah, Joan, do you want to speak to that a little bit? I can speak to some specifics here in Georgia, but okay. Several of our I think all of our CMOs are required by the Department of Community Health to participate in some outreach activities. So I believe there's a combination of like postcards, emails and text messages, and phone calls that are going out to Medicaid members at different time points related to like when their renewal date is. So if they get renewed on May 1st, then there's a time point when those things go out to that family to try to touch and make sure they get their renewal done. I know some others are kind of going above and beyond. The CareSource team was here this morning. They've got kind of a mobile van that will go out, and I believe all of the CMOs are kind of participating in community events to try to get to various parts of the state. But you're right, the fewer, as they're losing members, they're losing money, and that's definitely an incentive. So there are some specific things that our CMOs are doing, and I think they could probably speak more specifically to that maybe after the event. But Joan?
Yeah, no, that's absolutely right, and definitely the industry has been paying attention to this for quite a while. It comes up, one of my colleagues listens to their earnings calls, and it comes up on the earnings calls. So yes, there's a lot of awareness. The CMS has actually offered a number of flexibilities to states to mitigate inappropriate coverage loss. Some of these flexibilities relate to managed care plans, and I apologize because I didn't check to see if Georgia has taken any of these. But essentially allowing managed care plans to do more in the process, sharing more data with them so that they can see which one of their members is on the list for renewal that month, do like special outreach, that kind of data sharing, supporting them in the process. So there absolutely are ways that states can do more to involve their managed care plans, and that's critical, no question. And just generally, just to say, we have seen there's a new option because the Biden administration has become increasingly worried about the impact on children, and needless to say, this is going to disproportionately hurt families of color. Since they discovered the screw up in the household ex parte process, there's an option for governors to just pause for children for 12 months. Just stop. And what's a win-win about that is because children are mostly eligible anyway. And that allows the state to to focus on the adults, you know, people with disabilities. I mean, there are mistakes happening there, and that's very, very high stakes. It's a small number of people in sort of percentage terms, but it's extremely consequential. And parents, obviously Georgia's had a lot on its hands with pathways implementation happening at the same time. So, you know, in a perfect world, Governor Kemp would just stop. We've seen 2 governors do that in the last month, both North Carolina and Kentucky. The governors have come out and said, we're pausing, we're just stopping unwinding for children for 12 months. And we'll get everybody else done and come back to the children. So, in North Carolina is like, this is really a gold star. They're pursuing 0 to 6 in a waiver in the meantime. So they're going to come out of this with a new day for children. It's very exciting. Of course, they have Medicaid expansion too. So that is transformative change. So my colleague Tricia Brooks wrote about this, how to get a gold star. Governors, pause for 12 months for children, and then move to 0 to 6.
What other questions do we have? Or Alex, did you want to add anything?
I was just snapping.
We have suggested that our governor pause. There's got to be other questions.
I'd make a comment on the new provider types. Georgia is sort of ground zero for the peer specialist movement. You guys did it before others did. California just did it, 49th, I think. So there's an extraordinary history, I think, in honoring and centering lived experience. But there's, again, a last mile problem. This proud history had the architecture, the way I call it is like a pretty Christmas tree ornament on the dead tree. Like, the architecture of the peers hasn't been articulated to specific service lines, and you haven't made a commitment to family sustaining wages. So, yeah, as you add new provider types, community health workers, behavioral health technicians, my recommendation is something like this. Advocacy around wages. Like, would you want your daughter to make that much money? So have something that clarifies that health plans must reimburse at a living wage. I would set specific targets for empanelment, meaning the number of providers that get paneled, credentialed, and paid for the plans. Give this to the plans as an obligation. To be a CMO in this system, you must have 1,000 CHWs within 5 years, working in the following service lines and settings. And I think that needs to be done for CHW, behavioral health tech, maybe doula if you go down that road, and definitely for peers.
Absolutely. I think the wage piece is especially important because I know Georgia has a relatively robust community health worker workforce, but they're very low wage jobs, and so people tend to not stay in them very long, and then they move on to other things, which they will do anyway, but if we can pay them and sustain them in those jobs, that certainly improves the services they're able to offer to communities. Any other, we have another question.
Since nobody else has a question. So, I'm a data nerd. I'm also a Medicaid billing volunteer for a small safety net clinic. I live in the Gamma's portal, 2 hours a day. Some of the things that Georgia has done recently is, as providers, we can now, in the portal, update the patient's address and an email. Well, before, they never even used emails to contact patients. And I'm sure you all know, low-income folks tend to move more often than higher-income folks. We can also see when their Medicaid redetermination date is. Oh, this one is coming up in a couple months. When they're in the clinic, we better let them know. One of the things that we can't see, would it be nice if the Medicaid card had some kind of a generic expiration date on it? Like driver's license, I know when my driver's license has to be renewed. As far as I know, Georgia Medicaid cards do not have a date on them. And now, I guess with the unwinding, I believe it's tied to SNAP renewal, which makes sense. You go through the process twice, and it's, when they started, the state had a huge PR program that was contracted out. See, they've done a lot of things right. It obviously hasn't worked. So I guess my question is, what else? What are there lessons learned from other states that have been more successful in the unwinding process that Georgia can learn from? Say, okay, we've done a lot of good things, it worked. What else is out there?
Yeah, I think it's a great question, and obviously the eligibility rules are changing for children with the 12-month continuous, as we talked about right now. But in terms of what states have done to be successful, I mean, I think we're all, even though we had low expectations, like I said, they haven't been met, which has been really disturbing. And if you look at states that are doing relatively better, let's say, and a lot of states are not doing very well, probably the one most important thing is having a high ex parte rate. That's a little jargony, so I'll unpack that, but I talked about this earlier. Basically, when anybody goes through the Medicaid process, a state has to look at the available data they have. So they have SNAP data, they have wage data, other data that they have, and they have to look at that and make what's called an ex parte determination if that person or child is still eligible. And if they can determine from the information they have on hand, they just keep them on. So the family doesn't have to do anything. So for children, that should be, you know, doable for a lot of children. And so when you look at states that are doing well in terms of not disenrolling, if you had to pick one thing, it's having a high ex parte rate. I don't think Georgia has, I don't remember, but I don't think you have a particularly high ex parte rate.
We have a graph, I think it's at around 30%.
Yeah.
We've shown it a couple times today, but I'm guessing around 30% of my advisors.
So that's sort of the one thing, like, and just to give the example of who has the worst ex parte rate, it is Texas. They're basically not doing ex parte at all. I mean, which I think is a violation of federal law, but they're under 5% in their ex parte rate. And they're just literally kicking out hundreds of thousands of children and new moms. It's really shocking, but a lot are losing here in Georgia too. And that ex parte rate, and that's something to think about, right? Like if you think about modernizing the program, we don't want to live in a world in the 21st century where people are having to produce all this paper and information that the state basically already has, and its computer systems and IT systems should have that information available, and that's the best way going forward.
Yeah, I guess I would just add, for those of you who have worked in the gateway system to help people enroll or renew coverage, it's not an intuitive system, and I think that what we've seen in the unwinding is that that system has really struggled to keep up. The data that's imported from other parts of the state government isn't fantastic. So I think there are definitely some lessons learned from the unwinding, and I think one of them is that we have to improve our public benefits enrollment and renewal system so that it is much more seamless for families to use and pulls in the right data at the right time so that they are having to do much less input. So I think we're in our time for the panel, and I just want to thank Joan and Alex for being here this morning and just being fantastic supports to JHF and to many of the advocates in this room. I know we couldn't do our work without either one of you, and just really appreciate it. So thank you so much for this morning and for all of your work here in Georgia. And I am going to invite up Jennifer Baugh from the GFF board to close us out.
Thanks, Laura. Good morning, everyone. How are we feeling? Hopeful? Informed? A little pessimistic? Realistic? I'm Jennifer Ball, I'm a board member, as Laura said. I'm very proud to serve on this board that does great work. I'm learning so much by being a member. I'm also a community dietitian at Open Hand Atlanta, and I serve patients. I love that work too. I serve patients living with HIV and AIDS, and many of my patients fall in this gap of healthcare. And I see so many with social determinants of health who need community building blocks to empower them to live healthier lives. I'm mostly here as an advocate for my patients, and I really enjoyed the Only Doctor documentary segment that we saw. I hope all of us go home at some point this weekend and watch the full video. We have QR codes on your program and on our poster boards near the entrance there. I want to share a brief patient story. I want to keep him anonymous, so I'm just going to arbitrarily call him John. Sorry for any Johns in the room. This is not about you. This patient, he had trouble eating because of a tracheostomy. For those of you who don't know, that is a procedure where they have to open up your windpipe so you can talk and breathe more effectively. And he came to me because he needed help with eating. You see, his tracheostomy was not healing well, and those two pipes are, they're not connected, but they play into each other. And after doing my assessment with him, and he answered all my questions, it became clear to me that his liquid-only diet was making him malnourished, and unfortunately, without proper nutrition, that was going to become a worse condition and very much affect his life. Unfortunately, he has no access to what he really needed, enteral nutrition formula. And for those of you who don't know, that's a tube feeding procedure. It's not everyone's preferred way to eat, but it is a life-saving formula. And because of his health care, he did not qualify for this life-saving medical food. So I think about John often, and I do what I can with the resources I have. But like so many providers in this room, we can all tell you that we are short. And I was frustrated. I feel the frustration for his doctor, his social worker, and of course, I can't imagine how John felt. So we would like our hands untied, please, so we can help our patients. So that's why I'm here, and I'm sure all of you have a great reason to be here. We're all here to build a healthier Georgia, and for that, I want to thank you. I really like what our keynote speaker said, Alex. He mentioned Medicaid being the essential glue. I'm going to take that one home, so thank you, Alex. But we need to put more resources into making this glue and improving the glue. I could go on and on with that analogy. I want to thank our legislative panel. What I think I was hearing overall was that we have a great need here. There seems to be funds, surplus. We have technically budgets and money to spend on building up these programs, but I'm hearing still a lack of resources, so for me there's a bit of a disconnect there. When I was in college, I remember studying this theory that scarcity is a myth, and I want to bring that up today for this reason of healthcare inequality. I really like the suggestion of the tobacco tax increase, shifting around some funds to make more money for those who need it, since tobacco is not a necessity, it's definitely not a medical necessity. And I was hearing too that we're in this struggle between getting things done quickly and also making sure we have foundational building blocks set up for later success. I don't know about you, but in my job, I have to time manage, and I like to take care of the low-hanging fruit, to bring in one of my favorite analogies about food. So take care of the low-hanging fruit, and then I also pick away at the larger projects to make sure that my role is improved, so my patients' lives are improved. So I think we can do both simultaneously. It's not something that is lost on us as creative human beings. So we do need to look to, of course, patient care, but also recruiting providers that come from communities that are underserved, and keep them in rural areas, keep them in their communities where they know the patient best. So I also wanted to point out that even though the Georgia Pathways has not been a success for many, right, we still have an opportunity as we move forward. We have to go where the people are. This is not the field of dreams. We're not going to build it and they will come. We have to go where they are and build it there. We definitely have a lot of challenges in healthcare, right? We have to remember that there is a medical need if we redefine what medical need is. So when that comes to substance abuse and mental health and housing, we can, if we redefine these words, because the language is fluid, we can start seeing this as a medical need. So I want to thank all of you for staying till the very end today. GHF is very proud and appreciative to host this event annually at the start of the legislative session. And in your program, you'll see our top priorities as we go into this new session. I want to point out that we're going to improve quality and access by closing this gap and keep arguing for Medicaid expansion to get all Georgians health care. We want to increase access and recover hospitals and facilities that were closed or shutting down. We want to especially define better network adequacy and make insurance companies responsible for having those providers available. And I want to point out that yes, we have a long way to go, but we have had past successes. So I want to thank Laura about her story about the water dripping on the rock, because I think it is helpful for all of us to share our successes as we move forward in this battlefield. We do aim to pass the HB 404 to establish renter protections, and that is part of our Housing is Healthcare acknowledgement and initiative. We want to set adequate budgets too for housing for people with mental health and developmental disabilities. And we do need to increase pay rates for those direct support professionals and community healthcare workers who help Georgians with disabilities live more independently. We also want to retain, incentivize, and reward DFCS eligibility workers who help Georgians through the Medicaid unwinding and pathway enrollment process, and to expand effective pilot programs, some of this low-hanging fruit in the Department of Public Health, for example, properly funding home visits and programs that fight against new infections of HIV and AIDS through the PrEP medication that is such a wonderful miracle, but it is not getting into the communities that it needs to be in. So overall, we have to support public health, right, by investing in it. And I want to do a short call to action here. No matter who you are in the room, no matter your financial situation, there's a few options that I want to present to you, opportunities. So we have this wonderful initiative called Share Your Story. It's on our website where you can write down or video record your experience in Georgia's healthcare system, whether that's positive, negative, something in between. There's a lot of gray space after all. And this really helps us speak beyond the statistics and data that we collect and shows the human faces to the situation on the ground. And any of these call to actions you write, you have to do what's right for you, make it work for you. Maybe it's setting aside a little bit of time during your week to remember to contact your representatives, contact your relationships that you have, the other leaders in the room to get this done. Maybe it's just simply following us on social media to increase our visibility. Maybe it's telling everyone you know about GHF if you haven't already, right? Maybe it's putting in a little extra money to that donation ask. So I want to thank our sponsors. All of you are so appreciated, excuse me. But I especially want to thank the Georgia Primary Care Association and Georgia Health Initiative and Hemophilia of Georgia. I also want to ask you to save the date. We're going to the Capitol February 26th. Hope to see you there. It's Cover Georgia's Advocacy Day, so please put it in your calendars. Make it happen. And I wanted to lastly close with a quote from Dr. Martin Luther King Jr. After all, his observance day is Monday, and we're on his street right now. And when I think about the healthcare inequities that we see, I find this quote to really speak to that. He said, "The future of America is bound up in the present crisis. If America is to remain a first-class nation, it cannot have second-class citizenship."